chest pain talk about that goes along with a heart attack, or is it something else? I can tell you from experience, sometimes the chest pain is just that, it's chest pain. It sounds like they're having an MI, they're having an MI. But I've had some patients come in complaining of chest pain, and it has been a full array of diagnoses. So when we're thinking about that, you really want to think about by system and come up with a differential diagnosis. So is this something truly related to the cardiovascular system? So other than a heart attack, what are some things, just raise your hand or shout them out, you can think of that would cause chest pain? Yeah, costochondritis, so just some kind of musculoskeletal pain. What else? Yeah, sickle cell, so an acute chest or a sickle cell pain crisis. That's a great thought. What else? GERD, yep, not so much a CV differential, but yeah, going into GI, I like it. You're already starting to go down the system. What about from a respiratory standpoint? Can that cause chest pain if you have something going on with your lungs? Yeah, so what kind of things would you think about? Pneumonia. Yeah, pleurisy, exactly. We talked about some GI stuff. So what in addition to GERD would you think of? Yeah, so something with your esophagus. So you can have esophageal rupture, you can have esophageal strictures, you can have all kinds of things happening with your esophagus. There are a couple other organs that refer pain into your chest. The pancreas is an important one. That epigastric pain can present like just chest pain. And then what about neurologic? So anxiety, your patients can come in complaining of chest pain and palpitations, and they can suffer from anxiety or kind of somatization of other things that are going on. And then tying into dermatologic and neurologic, what's something else that can present with some pretty serious chest pain? Yeah, zoster, shingles, exactly. So already talking about this, something coming on with chest pain, your umbrella is cast kind of wide, and then you kind of tailor your workup and your management based on how your patient's presenting. So I thought that this was really lovely. It broke it into the system again. And we've talked about a lot of these things. So the cardiac system can absolutely be something like a single angina. Aortic pathologies like dissections or aneurysms, arrhythmias, which will go through valvular diseases, and then inflammation of the pericardium or the myocardium itself. So pericarditis, myocarditis, or tamponade, we talked about quite a bit so far. Pulmonary, you've talked about pneumothorax, can present with chest pain, pulmonary embolism, bronchitis, GI, again, going into your gallbladder, pancreas, and other GI etiologies, your MSK, and then your neurogenic cluster. The point being, obviously, assessing for all of these things at once is not possible, but you really want to get a good idea of what's going on with your patient from the second they hit the door, and then again, start tailoring your response accordingly. So your initial assessment, like everything else in the ER, is your patient stable or unstable? You're not going to want to spend 20 minutes talking about, their lack of appetite and their nausea, if your patient's diaphoretic, hypotensive. Really go and assess that patient. In practice and as a student, when you're in the ED, oftentimes these patients are triaged and have kind of a one-liner of what's going on that may be very accurate or very inaccurate. Patient stories change, patient's conditions change as they're sitting in the ER waiting room. So do what you can to see that patient as soon as possible if they're presenting chest pain. Check your vital signs and don't just check them once. Serious pathologies can present stable at first, and then that patient can deteriorate quite rapidly or unexpectedly. Every patient presenting with chest pain should have an ECG. Again, you want to think about those things that you should not ever miss in the ER, things like an acute MI, dissection, arrhythmias, things like that. And then they should be placed on continuous cardiac monitoring. This is not someone that should be sitting in the hallway unmonitored. No matter how busy things are, those patients need to be prioritized to be in a monitored bed. And you want to have IV access. You definitely don't want to be in the situation where somebody has chest pain initially stable, and then they're crashing in front of you and you don't have an IV to draw labs, get medication. So again, thinking ahead, hopefully this is not serious chest pain in your patient, but you want to plan accordingly in case it is. And then right off the bat, if you start by just getting vital signs and EKG and the chest x-ray, that provides you a really, really important information right off the bat, right? So you're assessing for anything under that CV, potential differential umbrella that we talked about. And then a chest x-ray, if somebody has a big pneumo, somebody has a lobar consolidation for pneumonia, that again helps tailor your response accordingly and helps you triage what you think is happening with the patient. So look at your patient, have them monitor, get an EKG, get a chest x-ray, and you can start the workup once you try and learn a little bit more about that patient. So one of the things that we'll talk about are cardiac biomarkers. And I'll go into detail with those, so thinking about troponin, CKMB, things like that. And again, other labs are going to depend on your differential diagnosis. I got the tail end of the conversation about the assessment that's being developed, but you really want to think about what labs are going to show you, give you the information that you need. So if you're concerned about a sickle cell crisis, CBC, let's go for it. If you're concerned about pneumonia, CBC, absolutely. If they have leukocytosis for the left shift, then you're concerned about infectious etiology. If you're concerned about the pancreas, get a lipase. It's not saying that you need a lipase on every patient, although you'll see in practice there's kind of a rainbow, what we call a rainbow tubes that are sent down to the patient. But especially as you're learning and you're getting experience, think about what results you expect. Think about what you're looking for when you take these labs. And you're not going to get them back for some time. So don't just say, oh, okay, I ordered my troponin, I ordered some chemistries, I'm concerned about X, Y, and Z. And now I'm just going to like think about that patient when the labs come back. These patients require reassessment. Again, starting with that EKG, the chest X-ray, and then tailoring other imaging based on it. If your patient's stable and you have a chance to talk to them, then you really want to get an idea of the quality of this chest pain. That's going to, again, help you differentiate what fits more in this ACS category and what might fit something else. So did this happen suddenly? Did it come on gradually? What were they doing when it happened? So sometimes it's more reassuring if it happens with exertion, and then when they rest, it gets better. That may fall into still a risky category, but it's not persisting while they're at rest. Does it go anywhere else? So chest pain can be very, very tricky. If you remember from your kind of basic anatomy lecture, you had visceral and somatic pain. Visceral is kind of vague, and it's associated with your internal organs. And so that's why you may have pain that recurs with kind of quintessential chest pain. So yeah, I feel this chest heaviness. It's not in this jaw pain, I'm not having pain or paracetamol within my left arm. It's those visceral fibers that are kind of mixing the signal between two. Whereas the mask is very specific. So it's right here. When I push on it, it's right here. I know exactly where it is. And that's more often associated with more of the skin, subcutaneous tissue, musculoskeletal tissue, down to the flora. This does not mean 100% of the time if your patient has reproducible chest pain that it's not something serious. But again, it helps you just kind of work down that pathway of typical chest pain with the associated symptoms concerning for ACS versus I need to listen to something with my patient. And then again, what made it better? Did rest make it better? Did something to help with MSK pain help? I took some ibuprofen, I feel better. Is this someone that has a history of coronary artery disease and nitro made it better, right? So getting more and more history to be worked on your decision tree. And then looking for some of those signs of a more serious condition. So are they dizzy? Are they suffering from palpitations? Are they nauseous, diaphoretic? Again, you've cast a wide umbrella in your mind, and as you're talking to and looking at your patient, you're tailoring it down to what's going on. This is aside from Professor Jacob's lecture last year that I really liked. It's your OPQRST. So just kind of qualifying your chest pain even further. So how did it happen? What makes it better? And then the 4 P's of chest pain is a positional, pleuritic, postprandial, and other palpitations. Again, with each of those qualities, you may start thinking it's a different etiology. Unfortunately, these chest pain diagnoses based on the description seem very tempting. Okay, if it's pleuritic, it's this. If it's, retrosternal crushing chest pain, it's this. Yes, that's helpful to use as a guide, but please just keep in mind when you look at this, your pneumothorax isn't always going to be unilateral pleuritic pain. Your GERD isn't always going to be burning substernal pain. And oftentimes, actually, with MI, just Pepsia and having that burning GERD-like symptom. But knowing what's usual is helpful as you work your way down.
And sorry to interrupt, and an important part of that is someone who's having retrosternal burning pain, and you give them what's called a GI cocktail, which is a mix of just lidocaine and Benadryl.
Yeah, Maalox, Benadryl.
Yeah, so it might make them feel better. It doesn't mean it was heartburn. It just means you numbed up the fact they're having a heart attack. Now, they don't feel anything, at least in the moment, then they die. It's great. It's bad news. So not everything retrosternal is GI.
Yeah. So again, helpful when you're thinking about that, but pain medications work on pain. So to Sir Jacob's point, you may treat that pain initially, but that doesn't mean that patient doesn't have something serious going on. We've seen this with aortic pathology too, when they get referred to us. So became hypertensive, complaining a little bit of back pain, and then we treated them and left them alone, and oh no, now they're really doing poorly, they're diaphoretic, they're having severe ripping back pain. Just reassess your patient after interventions and keep a close eye on these patients, because you may be falsely reassured. So again, we talked about the physical exam. This could be completely normal in your patient. So unfortunately, unlike other serious diagnoses where you may have these like pathognomonic physical exam signs, somebody with severe cardiovascular disease or presenting with a cardiovascular problem may actually look quite normal. So they may not yet be diaphoretic. They may be a little bit uncomfortable. They may be hormotensive, have a regular rhythm, not have any murmurs, gallops, rubs. Their GI, they may be non-compared to exam. So it's important to do an initial physical exam so you have their baseline. And if they do appear diaphoretic, they look in shock. We've talked about pool craving, rectally vasoconstricted. Then you can start working that up more quickly. But similar to the quality of the chest pain, just try not to slip into being falsely reassured that the patient's doing okay just because their physical exam on initial assessment. If they're nauseous, hypotensive, and diaphoretic, again, you're kind of triaging them more quickly and based on their hemodynamic stability and presentation. So when it actually is ACS, we're going to go through what ACS is, what you do about it, and how you go about managing these patients in the ER. So who remembers what kind of falls under the umbrella of acute coronary syndrome? What diagnoses? STEMI, yeah, and STEMI.
Stable and unstable.
Yeah, and unstable angina. Yeah. So STEMI and STEMI, unstable. I'll make up your acute coronary syndrome. We'll talk about all three, how they present. Lane Valentine's joke, number 2. All right. So first thing when we talk about chest pain and ACS is there's oftentimes what's described as typical or classic chest pain when somebody's having a heart attack. Coming with a caveat that your patient knows remember they don't read the textbook. When they do, it's very nice. They come in, they describe, and they say, oh my gosh, you know what? I just started having this crushing pressure like chest pain. But people have said to me, I kid you not, it feels like an elephant sitting on my chest. Great, I know what to do with that. You did read the textbook. It occurs during exertion and then maybe initially is alleviated by rest, but usually what prompts people to come and get treatment is the things that works to help this chest pain initially are no longer working. So if they have a history of coronary artery disease, they popped a couple of nitro, gotten some relief, and then it's just not working. And this feeling of indigestion is not going away. That's usually when they come and see you. Again, we've talked about that visceral pain that can refer to the arm, the neck, the jaw. And then in this classic or typical chest pain, it's often associated with nausea, vomiting, and paresthesia. So although this happens with greater frequency in acute coronary syndrome, they don't rule anything in or out, especially in different groups of patients. So women will describe pain differently. Diabetic patients, you know that diabetic affects you from a neuropathy standpoint, so diabetic patients may describe patients pain differently. Elderly patients that are underrepresented in these studies, so patients from underserved populations, and then those with altered mental status or communication barriers. I remember being an EMT in the ER, and I was working in triage, which is very, very mundane, and there was a woman with a language barrier, and she just kept telling us, my ear hurts, my ear hurts, my ear hurts. And she was just sitting waiting to be roomed, and I had nothing else to do, so I was chit-chatting with her. And through limited communication while waiting for her translator, she said, yeah, I haven't been feeling very hungry and I'm pretty fatigued. That's kind of weird to go with ear pain. Everybody was working up the pain, she had ear pain, so I just popped her on for an EKG and it said acute MI. I said, oh gosh, I don't know what to do with this. So we have a problem. This one shouldn't be in triage, right? But you have to have a higher index of suspicion when somebody comes in kind of with these vague symptoms. Oftentimes it's just feeling weak and generally unwell. And that referral of their pain, just knowing that you can have those visceral fibers that are causing the ear pain, neck pain, just always kind of paying attention. Also to your gut feeling, especially if you get more experience, you may just think this person doesn't look well, something doesn't quite fit. I want to investigate this further. So just know that although this is more common in typical chest pain, do pay attention to the fact that this does not apply to all patients. And in fact, several of the patient population that you'll see, they may not describe it this way. So we talked about some non-classic presentations, and then while getting a history from your patient, what would make you more concerned that they're having a heart attack? What in your history?
Smoking.
Smoking? Yeah, absolutely. What else? Yeah, hyperlipidemia. I heard family history. Absolutely. What else? Age? Yeah, think about age. Really young, really old. What age is between? Yeah, as you age, right? With atherosclerosis and all that. What else?
Obesity.
Say again?
Obesity.
Yeah, obesity, exactly. All these risk factors for cardiovascular disease. And then very obvious, has this happened to them before? So have they had an MI in the past? Do they have a history of coronary artery disease? Do they have stents? Are they compliant with their medications? All of those are really, really good thoughts. And then substance use, when you're kind of talking about alcohol and smoking, what else are you asking about? I heard cocaine. Why cocaine?
Calcifies your arteries, right?
Yeah, so it definitely hastens the atherosclerosis that happens in your coronary arteries, and more acutely, what happens if you can use. Yeah, coronary vasospasm can cause pretty significant MIs in young people. So I always preface this. I ask all my patients, no matter if they're a 99-year-old mom versus the 18-year-old that's coming in with something about substance use. And I always tell them this is not for any judgment, it's to make sure that any medications I give do not kill you and I can treat you appropriately. And really just setting the stage of I'm not here to rat you out, I'm not here for anything else, because it's really, really terribly important to understand patients better. But the stigma that goes around it can make them really bad. And then if you have a patient that has a significant cardiovascular history, I always find it helpful to ask, all right, well, what about this episode? Does this feel like when you have a heart attack before? Is there something different about this? And it can kind of, again, lead you down the pathway. They're like, no, this is my chest pain, but it does not feel anything like that. I think this is really my third. I think this is something else. You're still assessing for chest pain, but your index of suspicion is going down a little bit versus when this happened 5 years ago, this is exactly what I felt, and I feel like something is very wrong. Then you're kind of more suspicious. Either way, you're assessing for it, but again, we'll decide which pathway you're going down. And then there's something called a heart score. The EEG is all about scoring systems for the likelihood of something happening. They love it for PEs, for chest pain being something serious, because the job is really hard, right? So it's easy to sit back and say, oh, the ED missed this, how could they miss this? But they're bombarded with people with these vague complaints. It could be anything from the most benign thing, I wanted out of work today and my PCP wasn't available, to there's something actually going on that could be an injury. And so the heart score they developed, and it talks about the history, and I just love it because it's so subjective, but then you get them for like highly suspicious, it's moderately suspicious. So highly suspicious would be your quintessential, I have a history of heart disease, it's happened before, I feel like an elephant sitting on my chest. The EKG is going to be really important, and I won't belabor that because we're going to go into the EKG specific findings. The risk factors associated that we talked about, so age greater than 40, hyperlipidemia, temporal obesity, diabetes, all those things that make you high risk for atherosclerosis. And then troponin. So the important thing when we talk about cardiac biomarkers, you're not just going to get one. You may have an initial negative troponin, but it takes a while for your myocardium to leak that troponin when it starts to infarct. So you're not just going to have one. But it talks about being 3 times the normal limit versus 1 to 3 versus less than. If you have a suspicious history, if they're scoring high on this heart risk stratification, if you decide to use this tool versus something else, you need to make sure, again, your patient has IV access, and that's not a 22 in the finger. You need to make sure you have a good resuscitation time. You'd be shocked if that's how that happens. They need to be monitored. Supplemental oxygen is a newer discussion. So it used to be anybody with chest pain, you just popped in on supplemental oxygen. You now know hyperoxia can lead to vasoconstriction in port areas. So we just shoot for a SAT greater than 93. Having them on continuous pulse oximetry and vital sign monitoring, and then again, kind of expediting the treatment of these patients. They should not be sitting in unmonitored beds or out in triage. This is an algorithm that's developed based on the heart score. So again, a high likelihood, and you can see both of them, like I said, you're going to get serial troponins it's institutional dependent, but it's usually a few hours in interval or with changes in position. If your troponins are normal, you have a low index of suspicion for something serious causing this chest pain, then they can be more of a rapid rollout. If they're kind of in this intermediate, like they have a significant history, but troponins are elevated but not climbing. These are patients that are usually placed in at least 24-hour observation, and that may just be adjacent rooms to the emergency department. And then if there's somebody that has a higher heart score, their troponins are elevated, or even if they're not significantly elevated, they're increasing, they have not stabilized and they're not downtrending, then you need to admit these patients to undergo further workup. And bone of cardiology, because these are higher risk patients that need to have their chest pain elevated. ACS, as we've talked about, is defined as 3 different pathologies, so STEMI, unstable angina, and STEMI. And it's based on the development of the atherosclerosis and what's happening in the coronary artery. So remember here, you have normal lumen, nice intima, there's no development of atherosclerosis. In unstable angina and STEMI, what you have is significant plaque buildup that limits that flow to the coronary artery. So you can imagine that this may be why it gets better at rest, because you have less demand from that heart tissue. But then, oh man, when I'm going up those flights of stairs, or when I'm doing something tough at work, or when I get stressed out, any of conditions like that, you have increased demand and a limited channel for that hemoglobin to go through. So that's what's really causing your chest pain. And sometimes in the case of the NSAID, that troponin elevation, you're getting some myocardial ischemia with that. What happens in a STEMI, if you remember, is that plaque breaks off and becomes a really nice landing spot for platelet aggregation. This is a total occlusion of the coronary artery and causes really rapid infarction of your muscle. And, so that's why STEMI is treated so aggressively. Unstable angina and STEMI are treated aggressively as well, but a bit different because the pathology is different. Unstable angina is not included in this because it's basically the quintessential chest pain that alleviates with rest and nitroglycerin, and they're not making any worrisome or symptoms. Again, when we talked about this, you look at your patient, get that EKG as soon as possible. We have a really nice system in Maryland where oftentimes our PMS colleagues can send us a concerning ECG to the ED before a patient arrives. So you may have the luxury of, all right, they recognize a STEMI or something concerning, they send it to the ER, the ER has a room ready for them, and the cath lab's ready for them. Doesn't always work out that way. Often patients are coming home, but just keep in mind, it's usually not talked about, but that's something that's available in Maryland. We have a really great pre-hospital system here. When you're looking at the EKG, and we'll go through a couple together, you're looking for new ST segment elevation greater than 1 millimeter and 2 continuous waves, or new ST depression and T wave inversion. And we'll talk about kind of how those T wave morphologies change with the progression of myocardial ischemia. A new left bundle branch block, which can be tricky because not every patient can come to you and say, yeah, no, I always have this. It's maybe their first presentation, so they require a little bit more investigation. And then again, if you have a normal EKG initially, that does not exclude ACS. And you may have some ST segment changes that look like a STEMI that are due to something else. And so we'll go through all of that. But in general, these are the diagnostic criteria for a STEMI based on EKG. Any questions so far? Yeah.
How do you balance over performing an EKG and making sure you don't miss something?
Yeah, it's a really good question, and I think it applies to a lot of the work that's in the ER. You have to always keep in mind, again, that you cannot miss some of these problems. So even if somebody comes in with chest pain and it sounds more like dyspepsia and something else, get a baseline EKG. You're not overdoing it, and in fact, you may catch something that, again, this is a patient that may be female, diabetic, for whatever reason, not report the chest pain as quintessential ACS chest pain. So it's definitely not overworking the patient to get a baseline EKG. You should get that right. But you're right, it gets tricky because a lot of the ER is kind of preventing you from missing something serious, even you feel pretty reassured that it's not. But you just can't miss an MI in somebody. So definitely start with that EKG. Any other questions before I move on? So when we talk about ST segment changes and ST segment elevation, this is what we're talking about. So what you do is you compare the T wave to the isoelectric lines. You're going here and you're making sure that their elevation is at least 1 millimeter in 2 contiguous leads. Oftentimes when there's a significant ST segment elevation, it is more than that 1 millimeter. It's usually not that subtle, and that's what you see here. The other kind of qualifying characteristics that are common for ST segment elevation that's worrisome is that they're convex rather than concave. So you'll see over kind of like this tombstone pathology, which you can see more so with these bottom two. So they're convex rather than nice concave that you may see in some other conditions that we'll talk about. what this represents is its total, like through the myocardium, transmural ischemia and infarct, and that's why you're seeing these ST segmentations in your patient. The depressions and the inversions represent that subendocardial injury. So earlier phases of this before they progress to full transmural infarct or ischemia. So that's why serial EKGs, serial troponins, reassessing your patient, especially if they start complaining of more worsening symptoms, and not just feeling reassured that, oh, they're just some minor ST segment depressions, but no, ST segment elevation, I think they're okay. The way that they'll progress is initially they'll start having these hyperacute T waves, a sign that your myocardium is not getting significant oxygen supply. Then that T wave will start inverting, they'll become elevated, and then after an MI, you'll see persistent Q waves. Where the ST segment changes are can help you determine where you think the lesion is, where you think the occlusion is. So you can see these are nicely color coded, and these are the leads that respond to which area of the heart. Anterior septal MIs are associated with occlusion of the LAD. Inferior, again, LAD. Inferior in most people, so 80% will be the RCA. For that 20%, they could still be left on the LAD, and then lateral is the certain effects. V1 through V3 are important because they indirectly affect your posterior wall. So those are those patients that get a posterior EKG in. And then again, inferior wall MIs, I don't know how much y'all have talked about these in your EKG lectures, that you need a right-sided EKG. So V4 assesses your RV infarcts. If these are new terms to you, I can throw together something and send it out later about special EKGs for these pathologies. Cardiac biomarkers. So when we talk about that, we talk about troponin, CKMB, and myoglobin. Who is familiar with these tests? Even mildly. Okay, what do you know about them? What do you know about troponin? Comes from the heart, right? What about myoglobin? Where's myoglobin come from?
Muscles.
Yeah, it comes from your skeletal muscle, it comes from your heart muscle. And CKMB, also somewhat more specific for your heart, but really troponins are what's used in decision making. They are very sensitive, very, very specific to cardio. But they have different, similar to when you think about pharmacokinetics of your drugs that you're giving patients, there are different patterns to these biomarkers that are important to know, especially when we talk about their initial detectable level. So if somebody starts having chest pain, and they come in within a couple of hours, you can see here their troponin may not be elevated until 4 to 6 hours. So you could be really falsely reassured, like, oh, okay, their troponin's normal. They're probably not having a heart attack. I can kind of move on to the next person. That would be falsely reassuring. Please don't do that. You need to really get serial cardiac biomarkers. You saw in that algorithm, even for those quote low risk chest pain patients, you're getting serial biomarkers to rule out ACS. So no one EKG or one level of a cardiac biomarker is going to be able to help you rule in or rule out the diagnosis. It's going to be the trend of those. Troponin I is the most specific to cardiovascular disease, and we now use high sensitivity assays in the hospital. So I can't tell you any one lab value that's more abnormal because unfortunately every hospital system seems to use a different one. I don't know what it's like in urgent care if you're using a new high sensitivity troponins.
So in the nature of our lab is we don't get troponins back for 2 or 3 days after we send them in. So I never send them in.
Yeah, what are you gonna do with that?
Turns out you're having a heart attack.
Yeah. Good luck.
I hope you're so,
Yeah.
glad you're answering the phone.
Oh, yeah, yeah. So sorry, I can't provide you with a normal reference range. It really is gonna depend on where you practice. Yes,
Sorry, to go back to the previous slide,
yeah, you got it.
when it says can exclude if 2 samples are within 3 hours.
Yeah, so those are your low risk patients. If you remember this algorithm, and that will be institution specific. But usually it's at least 2 to 3 serial troponins, so over the course of about 6 hours. And if you have a low risk patient who otherwise is fine,
3 hours is enough.
low concern, then for some, most institutions, they'll say, okay, every 1 to 3 hours, get a repeat troponin. And if troponin stays negative, your EKG stays stable, your patient's condition has improved, and your initial suspicion was very low, then that may be a rule out. This is not set in stone. This is very institution ER specific. But it's just a way of helping triage and rule out those low risk patients.
And a super important part of the history of any chest pain is when did it start?
Right.
Yeah.
Because that's gonna play a role, if you look back at that chart, right? If the chest pain started, like 10 hours ago, and they have a negative troponin, it's a lot more reassuring than if it started 15 minutes ago, they have negative, right?
Yeah, and so that's by knowing that this initial detectable level, and then again, when they peak, you might have somebody that may have come in and they may have missed the MI at home, particularly. So you may have an elevated troponin, but it's peaked, it's like 24 hours later. You can see here, that troponin can stick around for 3 to 10 days. This gets super tricky when you had a patient that came in for ACS and then you discharge them, and then they're freaked out because they had a heart attack and have nuisance and they come back in with chest pain. What the heck do you do with that troponin, right? And that's where trending, patient condition, comparing to before, it's all really important. So knowing what your troponin is measuring, knowing when it's initially detectable and when it peaks and then it's finally cleared in your system is really important to know how to manage these patients. Going through another algorithm that was from Finelli as well that I think is really nice. Again, starting with your history of physical examination and EKG, you can basically differentiate ACS into 2 categories. One is you recognize your SEMI, which is one of the most time-sensitive emergencies that you have. And I should have asked you before I did this, but hopefully you remember somewhat how you manage SEMI, which is first you want to stop that platelet aggregation. So you give them antiplatelets with aspirin, Plavix, or Brilinta. Nitroglycerin can help alleviate that chest pain because remember that that's a vasodilator, and so it's opening up those coronary arteries so they can improve blood flow. Beta blockers, I would not give in an acute MI. It's a negative inotrope, and so it's on some algorithm to be very careful. You have a heart that's experiencing a bunch of ischemia and potentially it's going to develop cardiogenic shock. Beta blockers are usually something that we give after the acute phase of events, and that's maybe a complication of the MI. And then either Lovenox or heparin, most commonly just a regular heparin drug for at least 48 hours. We'll get into how you treat this, whether you give thrombolytic or PCI. PCI is always preferred if you can get them to a coronary cath lab within 90 minutes of their first contact with medical professionals. So once they hit the door, if they can get to a cath lab within 90 minutes, that's preferred. It's more definitive. Yeah.
All right, last question to go back. So we don't order CKMB anymore? Okay, so you don't order anything except, and then maybe a BNP.
I don't know if others do, but the practice now is your decision is based off of that.
I don't remember.
No. You may be tested on it, there's an old question. So
Right, that's why.
Markers, but in practice, they're the most sensitive and specific for looking around in mind. If you have an EKG that does not have ST segment elevations, so it could either be non-diagnostic or ischemic with maybe some ST segment detections or T-wave inversions, you still want to give them aspirin, Plavix, nitro if they're having chest pain, and some other different drip. Again, you're trying to prevent the propagation of any kind of clot and promote flow through that already pulmonary artery. The management of this becomes a little bit more controversial about which to send these patients to Athlon. It's not quite as emergent, but if they still have a high risk EKG, if their symptoms are concerning, if they have a pretty significant history, these patients get more urgent intervention with a PCI versus just medical management. The things that you can also do to help these patients are analgesia. So when you're in pain, when you're anxious, you're going to be more tachycardic, you're going to increase your myocardial oxygen demand. So treating pain, we can support patients as well. And then making sure that you reassess them. So if this is somebody that you think, initially was doing okay, you treated their pain and then they're getting worse, and they were initially in this non-diagnostic or ischemic ECG group, get your repeat EKG, make sure that they're not developing a SEMI, and get cardiology involved as soon as you can. Talking again, yeah.
I was just gonna ask, I know morphine has been a really controversial debate these days, in your practice, do you see it still used? Do you see it not?
I do, yeah, a lot of people do use morphine. Be careful in patients with renal dysfunction. Has ICU component that can lead to some basic declaration. I should know the most up-to-date evidence with this, but I think it's something that's not in place. But it's definitely want to know what you're giving. I agree. likely to affect. We use, in the ICU, we use fentanyl and melodic quite a bit. Some weeks we'll use morphine. I just find morphine if they have like those patients too. Some patients like, for whatever reason, require quite a bit. So a lot of our patients don't have healthy kidneys to begin with. So morphine's fine. That's probably what you're going to be when you're testing on this. But in practice, I think we use a whole array of situations. We're talking about how to get treatment for them. So PCI versus fibrinolytics. PCI for percutaneous coronary intervention. This is getting them to the cath lab. It's diagnostic and therapeutic, and then some people do an angiogram, see exactly where the lesion or lesions are. And then if there's something that can be opened up with either angioplasty, so that's where they literally put a catheter in, they put a balloon in and force that area open, versus leaving a stent through that. You can see this, why this would be preferred to fibrinolytics, because fibrinolytics will bust up whatever clot may be there. But it doesn't fix the underlying atherosclerosis, the underlying occlusion that led to this. And so most of these patients will be referred to a PCI at some point, either urgently or more routine, depending on how serious their condition is. The recommendation is that fibrinolytics can be given if you cannot get to a PCI within the first 90 to 103 minutes from the first medical contact. So similar to getting somebody to a stroke center, time is brain, time is heart. They really want to get you to the best treatment center as soon as possible. But for those patients in rural or communities that are unable to have this resource, then fibrinolytic. You still continue with full dose anticoagulation in both groups for 48 hours. And then again, in this fibrinolytic group, you may follow with an invasive evaluation and treatment. I would say more often than not you do. You also have patients that have contraindications to fibrinolytic therapy. Are you all familiar with those, or have you talked about those so far? Okay, what kind of patient don't you want to give clot busting drugs to? Someone that's bleeding. Yeah, absolutely. When the real mess on your hands. What else?
Blood pressure over 185.
Yeah, so somebody that's severely hypertensive because of the risk of hemorrhage. Anybody with a history of a recent stroke, anyone with a history of aneurysm dissection, make the high risk of bleeding. Spinal surgery or head or neck trauma or spine trauma within the last 2 months. And then anything that increases the risk of bleeding. So somebody's already at high bleeding risk. It's contraindicated. It gets tricky when somebody's on anticoagulation as an outpatient. I don't think people have a good answer for this in general. It's really going to be a condition. All right, so we talked about acute management, which is wide umbrella of differential diagnosis, really keeping ACS at the forefront of something that you cannot miss in a patient, getting those serial reportings, getting the EKG, and then risk stratifying your patients based on their conditions or comorbidities, and then the workup that you've initiated. Someone's had an MI. What are some of the things that happen after an MI that are complications that increase their mortality?
Remodeling.
Yeah, cardiac remodeling. Absolutely. What do you mean by that?
Like when the tissue dies, and it becomes weak, so then the other tissue around it kind of bulks up to compensate.
Yeah, absolutely. So you can have changes in that myocardium, that ventricular function too. So you have persistent heart failure, cardiogenic shock. And what else?
Kidney problem.
Yeah, and organ problems because your heart's been not working properly. What else can happen?
Dressler?
Say it again.
Dressler?
Yeah, Dressler syndrome. That's that post-MI inflammatory syndrome that usually happens within a couple of weeks where they have recurrent chest pain and fevers. Yeah, what else?
You can add.
Yeah, absolutely. What else? That myocardium can be very irritable. It's been lacking oxygen and good blood supply for quite some time. So these patients are at very high risk of arrhythmia. Most commonly is atrial fibrillation, especially in those first few days after MI. Ventricular arrhythmias are going to be a very high concern. So just keeping that in mind. Other things that can happen. Your valves are supplied by your coronary arteries. And so one of the most common things that can happen that's pretty scary is mitral valve, capillary muscle rupture, excuse me, and acute mitral regurgitation, which carries a really high mortality. The remodeling that we talked about, so this can be LV aneurysms, the papillary muscles that we talked about, and then inflammation of pericarditis syndrome. So just keeping that in mind, once you've treated the MI, you're not necessarily out of the woods. And again, these patients may represent to the ER with these problems after they've suffered an acute MI. So getting that good history is really important. In patients that have persistently low ejection fraction, so less than 25%, they can be worked up for a life vest. You want to treat sinus tachycardia in these patients actually, because that's increasing the myocardial oxygen demand. That's why beta blockers after the acute phase are started. Persistent ischemia or persistent shock, they may need mechanical circulatory support, and then with Dressler syndrome, with that chest pain fever, within a couple weeks of post-MI, we treat with colchicine. There are special populations with ACS. What do you think is going on, or what do you think you should be worried about in someone that just went to the cath lab, got their stent, and then has recurrence and worsening of their chest pain? What would be really worrisome to happen to this patient? Bleeding, that's a good thought. What else?
Another infarct?
Yeah, another infarct. It's specifically reocclusion of that stent. So this can happen, the drug-eluting stents, before they kind of become epithelialized, they are very, very reliant on their fecal antiplatelet, and they can be occluded if those are stopped or missed for any reason. So be concerned about a reocclusion in those patients. It happens, unfortunately. We see it not often, but enough that it's a recognizable problem. Cocaine and amphetamine induced ACS. Again, there's some debate in recent literature about this, but historically you should avoid beta blockade acutely in these patients because you basically block the counteraction to that alpha agonist action, which means you can worsen the disease stuff. There's not a lot of good evidence to support this. It's more of a historical teaching, but I will say in practice we still err on the side of caution because if it is true in any patients, you really don't want to create that unopposed alpha vasoconstriction in somebody that's already suffered a myocardial ischemia. Those patients who come in after hours or weekends or when your ER is really busy may have been sitting in a waiting room smoldering for quite some time. So because of that longer wait, they may present to you when you finally get to see them as more acute. So pay attention to those patients who have been sitting waiting for a while. And then patients with a history of COVID. We saw this when COVID was really bad. We saw a significant increase in a few things. Myocarditis from COVID itself, not just the vaccine. We saw an increase in myocardial infarction, as well as pulmonary emboli. So it's a hypercoagulable state and microvasculature. So patients with a history of COVID with these symptoms should raise a little red flag in your mind. Sure, it could have been the visit coughing for a week and a half. That's your maybe more common, but less risky diagnosis. You really want to make sure that you're following the serious things that can happen. This is just another nice algorithm of how you treat somebody with ACS. They're having STEMI, we open up that clot either with cath lab or lysis, and STEMI. The differentiator between fecal angina and STEMI is a positive development. So fecal angina is at risk of deteriorating to an STEMI or STEMI. Remember, STEMIs and STEMIs are defined by the pregnancy. A couple more things to think about that are just kind of tag along when talking about MIs. There's something called Wallenstein that I think is important to know. I don't know if we really stressed this when I went through training, but I will say it's come up several times in my care of patients with cardiovascular or HAV comorbidities. And what Wallenstein is it's these abnormal T waves that you usually see here in V3 and V2. You can see they're a little bit biphasic, so they're first normal T waves and then they're inverted here. And they may have any kind of morphology, but those kind of inverted, deeply inverted T waves in V2 and V3 can be pathognomonic for critical stenosis of the LAD. So you may see this before any kind of MI in the patient, but if you see these changes, or if you see this and you don't know if it's baseline for the patient, you should be concerned about LAD pathology. I actually recently had a patient for a completely separate issue that was not cardiovascular in nature. Ended up having a bleeding complication, and I had some vague complaints that wasn't a quintessential chest pain. And when we got there, initial 12 lead, he had some biphasic T waves in V2 and V3, and then started feeling more and more well as time went on. So a couple hours later, we got a new one and had some very, very deep T waves inversion in V2 and V3 and with that cath lab, and he had re-included in the LAD stent. Just because why not? While you're there for something else and then have sleeping complications, you do it. So Wallenstein is important to know just because it can kind of raise that flag in your head that they may have some stenosis with their LAD. And these are what we call dynamic changes. So when we talk about getting repeat EKGs when patient symptoms change, those are dynamic changes to the EKG. So they may have SC segment changes with exertion, with increase in chest pain, with anything else that's happening. So we talk about dynamic changes, that's what we're referring to. And then a left bundle branch can be tricky, especially if you know that they had it in the past where they're presenting with concerning symptoms. Thankfully, we have modified scarbosis criteria, which is actually pretty useful. We'll get patients with pre-existing left bundle branch blocks who are complaining of chest pain. And you really don't know what to do with it because, okay, that's an ACS indicator. So what do we do? It just becomes very, very challenging for these patients. So they have different EKG standards for what defines a STEMI. So it's ST segment elevation and supporting leads, ST depression in V1 and V3. And then they can also have, in a peripheral lid, they can have the supporting ST segment elevation greater than 5 millimeters. So what that means is it's not in this, I go all the way back. We're talking about discordant leads. We're talking about maybe it's in an inferior lead and a septal lead. So not something that necessarily goes together in a normal distribution. But the ST segment is so elevation is so increased greater than that 5 millimeters that it's concerning for ACS. And you'll see this used in emergency medicine quite often for those patients with blocks. As we talked about, not every cause of ST segment elevation is a STEMI, unfortunately. Inflammation and infection, so pericarditis and myocarditis can cause ST segment elevation. Is anybody familiar with what makes it different than an MI on your EKG?
Isn't pericarditis in all leads?
Yes, it's diffuse. So when we go back to talking about kind of that anatomic distribution, you have diffuse ST segment elevation. What else might you see in that? It's fine if you don't know what we're talking about. PR segment shortening and depression can also happen. And then you don't have those reciprocal changes. You're not seeing ST segment, you make two-wave inversions in those reciprocal leads or those opposite leads reflecting that myocardial ischemia. And it's just due to inflammation of the myocardium, like pericardium. You may see what's called early repolarizations, and we talked about the convex nature of those T-wave changes or ST segment elevation changes. If you have a concave, that's just an early repolarization variant. I would say you have to feel pretty confident to call it that. Again, you're still getting serial biomarkers, you're still hopefully getting cardiology to take a look at that EKG before you just say that it's the most benign thing possible. But the morphology, again, can be a little bit more reassuring. LVH and LV aneurysm, so those remodeling changes that occur after an MI, specifically the LV aneurysm, can result in just persistent ST segment elevation. So that's why it's important if you're able to review old imaging of these patients' EKGs and their history. It can help you with your differential and feeling that more reassured that this is not an acute pathology patient. But if you keep going, twice as good. Why should not do this all the time? All right, so we've talked about evaluation of chest pain. We've talked about ACS. Any questions about that so far? We'll do syncope pretty quickly, because again, this is more focusing on what causes syncope and what you have to evaluate in the EKGs. And then we'll take a break before going on to the next segment. Does that sound okay? Okay. Who remembers what syncope is? All down over, right? Yeah, so the transient loss of consciousness and loss of postural tone. So this is where somebody loses consciousness transiently and kind of falls over or slumps over. What defines syncope as well is this patient doesn't remain attentively responsive if resolved without intervention. And some patients may experience what's called near syncope, which is where they feel that they're going to faint or lose consciousness. They look kind of unwell. They lay themselves down as they get a little bit better. It's usually caused by a transient loss of blood flow, so due to relative hypotension, but can also be due to some more serious things, including toxin, metabolic abnormalities, CNS abnormalities, and hypoglycemia. So when you have a patient that presents with syncope, similar to dizziness, it's kind of a frustrating diagnosis because it can be a lot of serious things, or it can be something as benign as I don't like seeing blood being drawn. So what you want to do in the ER is you want to think about what could hurt my patients that's causing syncope that I need to rule in and rule out. So what makes syncope different than a seizure? I heard under versus overactivity. I like that description. What else? Say it louder.
Loss of consciousness.
Yeah, so both you'll lose consciousness transiently, so it can be a little bit hard to differentiate. But you may actually see this motor dysfunction in the seizure. So you may see tonic-clonic movements or shaking. And then after a seizure, patients have post-vagal states, and so they're terribly confused for a few minutes, which may happen after syncope, but is, I would say, more in line with seizure activity. And we rely a lot on witness reports, so EMS versus whoever saw this person go down, whether or not there was some shaking activity and what it was like when they came back. It's important to know the duration of how long they were out. Again, in deciding how serious was it and what etiology it could be due to. A prodrome is important too. So if somebody can tell you, I just felt really sick to my stomach, I felt lightheaded, my vision started going strange, and then I was out for a second. That can help you differentiate as well versus no prodrome makes you think something had changed in this patient's condition. And then inciting events, what were you doing? What was happening before you think has this happened before? And then how are you feeling now? So somebody that syncopizes and then presents feeling very well is much more reassuring than somebody that syncopizes still has this kind of foreboding feeling or now has chest pain or a headache or something else that would have you working down a different differential. So what can go wrong that makes somebody faint? Something wrong with their heart. So poor cardiac output for whatever reason, a valvular abnormality. The most common cause is vasovagal, which is that patient bears down, their parasympathetic takes over, and they just transiently lose that tone and that blood flow to their brain, and so they syncopize. Thankfully, the most common is also the most benign, but again, you can't miss other things. Orthostatic hypotension, which we've talked about previously, which is either due to dehydration or poor tone. When you change positions, your body's not able to augment your venous return. You don't have enough blood flow, and so you have a transient episode then. So consider this as somebody that's had a GI bug, somebody that's been doing any kind of exertional activity that would be dehydrated. In arrhythmia, we talked about that sudden onset with prodrome. So get those patients at 12 lead in onto them through monitoring, so FQT, VTAC, any kind of arrhythmias we're going to talk about shortly. And then disruption of blood flow, either from cardiomyopathies or vascular diseases. They may have started a new medication, they're on a beta blocker. A bunch of things could be going wrong to cause it. So you really want to get a great history, figure out if this has happened to your patient before, and then assess those more serious causes. Got a good comprehensive physical exam. Now, are they having subtle changes of unilateral weakness? Are they now having a regular rhythm? They're having their pulses. Are they having any crackles, wheezes, any evidence of heart failure? Do they have peripheral edema? Does it look like they're in shock? Are they having any pain? Is this somebody that, they forgot to mention they were in a low speed car accident 2 days ago, initially felt fine, then you look, they have seatbelt sign in their abdomen, worried about bleeding and vascular spaces and some. And then patients that you're concerned for GI bleeding, you get the full blood and your rectal exam. Again, just going down your differential based on their presentation, thinking about what could hurt them versus what's going. I will say when we would triage in the ED, most often in the younger patients, they would know like, hey, I was getting my blood drawn, I saw my partner getting their blood drawn, I don't like it when I'm having versus the elderly, they have more vague complaints that I would say they're a little bit more at risk for some of these more etiologies. They're just being careful and work those patients up. And then of course there's an algorithm in the ER. So it's all dependent on what you think your diagnosis is. So if they have unexplained syncope, then you have to do a risk stratification on them. Again, are they elderly? Do they have more comorbidities? So if you someone that now has a few onset arrhythmia, then those patients need to be admitted and monitored. I would say cardiac is the most important system really that you can miss with this patient. So echocardiograms are going to be really helpful along with their monitoring. Low risk, I would still be cautious about sending these patients home. You really want to observe them, make sure they're asymptomatic, and make sure that you think you know why it happened. So don't just send somebody out of the ER because they look like they don't know why. So that's a pretty risky situation. It's gonna be somebody that had a PE as well, we see that not infrequently, so transit obstruction. And then if they have a clear cause and it's dangerous, they're obviously gonna be admitted, and then you're working on the treat those things, so we have got neurologic disease, hemorrhage, pulmonary embolism, cardiac disease. And then those last 4 reasons, so it really comes down to the history and how your patient's presenting and what differential diagnoses you've been able to rule in or out, which potentially be very dangerous for them. Yep. Yes, exactly. So they're complaining of, oh, I've had some dark or bright colored stools. It's, and don't forget your young patients that may be pregnant as well. This could be a next topic. This could be a missed abortion. So evidence of bleeding or something, they could do that. So don't do this on every patient, to your point, but just if you have that, and then that's a suspicion, it's going on. Yeah. What else?
And one of the things that students have asked in the past, carotid hypersensitivity, that's your classic, like, 25-year-old relatively healthy male shaving. And like, as he was like shaving, he hit his carotid, it's cut it, but putting the pressure on the carotid caused him to pass out. So that's, you get that in the history of shaving. That's that. There's no other risk factors. So elimination, it's a diagnosis of exclusion, but that's what it is.
All right, so the takeaways from this section were always assess your patient's stability first, prioritize your ABCs, quickly assess for acute myocardial infarction. That's one of the top things that you cannot miss in these patients. Keeping your broad differential and prioritize ruling in or out potentially life-threatening conditions, and then reassess your patient. The ED can become busy, patient's conditions can change. Make sure you're assessing after interventions or if there's any change in their symptoms or conditions. Sound good? Experts? All right, like what, 5 to 10 minutes? Yeah, okay, take 10 minutes. Candy off of that. I'm not gonna more. I'm just gonna kind of cut it. But I do abnormal. One part, which is what do you do about it? Arrhythmias are one of my favorite things to talk about. Again, similar to pain, you'll encounter them wherever you go. So we'll go through it systematically, which is know your normal, and then break it down into how to, that's your abnormal and how to do it. There's gonna be a lot of EKGs review. You'll also get this in your photo class. So Monday you have someone to speak to you about EKGs to go through. And then you and I are gonna go through negative code scenarios. Where we will have code cards, we will go through each scenario where we talk about and figure out what medications we pull, how you kind of triage that and who does what, right? So, you'll get more and more EKG. The plan is just repetition. So we shouldn't be experts right now, but we should be starting to recognize certain patterns to be able to go through. Ella really helped with that. That book was on this little table behind the couch, and she climbed up there, and I was like, "There's no way that book's the size you are." Sure enough. Another.
So
I'm not taking that home, you know, better.
I will.
All right. Know your normal.
I will catch that.
The going through EKG and the way that we measure the cardiac velocity, you have your T wave, which is your atrial depolarization, or and your T wave, which is your polarization. And a normal conduction pathway, you have your SA node that keeps your heart rate lovely 60 to 100 beats per minute. Your AV node, which has an intrinsic rate ability of 40 to 60 beats per minute. And then the bundle fits down your bundle branches into your ventricles, which can generate rates of 20 to 40 beats per minute, kind of an escape of what. So there's a lot of protection when it comes to the heart's ability to generate a normal rhythm and normal heart rate. But when those things go awry, it's pretty serious and you need to triage these patients quickly. So when you know you're normal, the next thing to know is you're abnormal. And thankfully, there's a way to think about this and triage this, which is there are very few wide complex arrhythmias. Those are ventricular tachycardia, ventricular fibrillation, and you'll hear things like other what may be narrow complex arrhythmias with potent aberrancy. So that's when you have a pre-existing bundle branch block and it may appear wide. But again, that's a diagnosis of exclusion. If it looks like VT, we treat it like VT. And your neurocomplex, you're broken into your sinus rhythms, and then those that generate the SA or E. Produce those neurocomplexes. Step 3, so you know you're normal and how to assess normal, you know your differentials of abnormal heart rhythm. Step 3 is your patient stable or unstable? This is going to help delineate how you treat that patient. In a stable patient, they're normotensive, they don't look like they're in shock, they can communicate with you, and they're not yet showing signs of malperfusion, but like everything in emergency medicine, keep in the back of your mind that these patients who have arrhythmias are always at risk of decompensating, so having access, in your unstable patient, that's going to be defined as your patients that are hypotensive, so they're suffering from end organ dysfunction because of the lower cardiac output. They're symptomatic, so these patients have chest pain, dizziness, palpitations, and then they may present like they're in shock, so vertical restricted, full extremity altered. So is your patient a normal sinus rhythm? Yes or no? Do they have an arrhythmia? What kind do you think it is? And how stable is your patient? Your stable patients are going to have more time to figure out what's going on, to treat them medically, to do some more investigating. Your unstable patients, you treat and stabilize rapidly. So in those stable patients, get some more information. So why is your patient having more arrhythmia? Do they have underlying structural heart disease that they're aware of? Do they have a known abnormal heart rhythm? Maybe this is nothing particularly worrisome. They're asymptomatic, they're coming in for something else, so they happen to have atrial fibrillation or abnormality. If they're coming in with chest pain or symptoms in an arrhythmia, they're otherwise hemodynamically stable, then you get some more information about what's going on with them. Is this something that's happened to them before? Do they intermittently go into AFib, RVR, get symptomatic and do something about it? Do they suffer from bradycardic episodes? Knowing their history, what's helped them in the past is extremely helpful. So again, somebody can present an atrial fibrillation, but if that's not the cause of their symptoms, it's a little bit less worrisome. If they're in atrial fibrillation with an rapid heart rate and hypotensive, that's more worrisome. So getting some context as to how this originated, how symptomatic this particular patient is. For past medical history, you want to know, do they have a history of cardiovascular disease? Do they have any other reasons that they may have abnormal heart rhythm? So have they had prior cardiac surgery that affects their heart rhythm? Have some overlapping information. And then do they have any endocrine disorders? So what endocrine disorders? Hypothyroidism. Yeah, disorders of the thyroid. Hyperhypothyroidism.
I think these couple.
Yeah, I like it. About things like catecholamine, extra catecholamine. So something like a pheochromocyte. So a lot of epinephrine. Surgeries, like we talked about, specifically cardiovascular surgeries, like manipulate the conduction system of the heart. Medications, so if your patients are taking diuretics and dumping out a bunch of potassium and magnesium, that can predispose them to arrhythmias. And then are they on antiarrhythmics? So your patient presenting bradycardic, they're on a bunch of beta blocker, this would be the pretty easy diagnosis and solution. Like, hey, they just increased my metoprolol last week and my heart rate's 50 instead of 70, or 45 instead of 70. Symptomatic. And then family history, does any history of sudden cardiac death in the family member? Do they have a history of long QT syndrome? AFib in your family? So any of these things that can predispose you to have yes, and then substance use. One of the most common that you'll hear about is atrial fibrillation in patients that binge drink, so it's called holiday heart syndrome. Around the holidays, people have excess alcohol use and present with exacerbation of the again, although these patients are stable, you're preparing for them to not be stable, so you want IV access in them, EKG and cardiac monitoring. And then again, similar to everything else, yes, you're probably going to get all of the labs that are normal in the workup to get CMP, CBC, but also think about what you're looking for. So anemia and low hemoglobin can cause arrhythmias because that's causing a relative low oxygen state in the heart. Leukocytosis, if they have an infection, that's causing arrhythmia. The CMP, looking at your electrolytes, looking at end organ dysfunction if they're symptomatic from this. Thyroid function tests, BNP, if you have a patient that you're concerned about heart failure and want to look at their status. Troponin, we just went over this, and ACS, you may have an arrhythmia because of cardiovascular disease. And then a lactate, which we know is a marker of end organ malformation. So that's some of the things that you want to be thinking about as you think about this. In the unstable patient, you treat the arrhythmia and then do some investigating. So these are patients that are hemodynamically unstable because of their arrhythmia. Again, you need IV access, EKG, cardiac monitoring, for all of these patients. And then we'll go through the arrhythmias and talk about which medications you can use instead of electricity. And again, stable patients always have the potential to become unstable. As we talked about before, you can divide these arrhythmias into narrow and wide complex. We're going to start with our narrow complex arrhythmias and go through what's normal, what's sinus rhythm, and then go into some of the other tactic arrhythmias. Hopefully some of these things will be repeats. I know that we specifically have talked about atrial fib and some of these malignant arrhythmias. So I'm going to quickly, or if you want to stop and ask a question, just raise your hand. Because otherwise I'm going to focus more on the recognition of potential management. So normal sinus rhythm, that means that you have a rate of 60 to 100 beats per minute. You have a P wave for every QRS. Your P waves are upright and consistent in your 12 lead normal PR interval, normal RR interval. Your QRS is not wide, it's narrow, and your patient has a pulse. Why would I put that on there?
PEA.
Yeah, PEA. This will fool people sometimes. They could be headed to you with our awesome, pre-hospital colleagues, and for whatever reason, patient looked okay, that they arrive and you go, oh crap, they don't have a pulse, but they have a rhythm the whole time, they just don't have anything. Sounds silly, but it happens. It happens on hospital floors, it happens. So assess that patient, just because you're looking at this one, you don't necessarily think they're gonna be okay. Patients in normal sinus rhythm, just being silly, this is again part of the lecture that I give to my critical care colleagues, so you're always going to hear me say prepare for first because patients have the potential to be compensated for normal sinus rhythm in itself is not a condition. Sinus tachycardia is all of those nice descriptors, but a heart rate greater than 100. I think of sinus tachycardia as a symptom of something, not an independent raw problem. So sinus tachycardia doesn't just happen, it's a symptom of something underlying. So you want to figure out why they're tachycardic. Are they anxious because they're in your ER? Are they in pain from something else? Are they febrile? Are you worried about sepsis? Have they been given a bunch of diuretic? Are they hypovolemic for whatever reason trying to compensate? Are they in decompensated heart failure, which are their augmented output? Don't just treat sinus tachycardia completely like that. Figure out why your patient's trying to express that. Because again, I put this under here and talking about the patient in heart failure. Your cardiac output is your stroke volume and heart rate. So if your stroke volume is down for whatever reason, again, dehydration, sepsis, then you're going to try and augment that cardiac output by increasing your heart rate. So it's a symptom of something and warrants investigation for tachycardia, but shouldn't just be treated in isolation. Sinus bradycardia, again, all of those qualifiers under the definition of what a sinus rhythm is, but now your heart rate's less than 60. How you treat a patient with sinus bradycardia, like most arrhythmias, depends on your patient's stability. And you want to know the cause. So why is your patient bradycardic? Maybe it's something benign, like your patient's very athletic, they have a very healthy heart, and you just have a resting heart rate in the 40s. That happens because the myocardium is efficient at moving blood flow. Are they hypothermic or hypoxic? Something else like do they have hypothyroidism where everything's kind of moving slower? Are they having an MI? Are they knocking out their AD node related to other bradycardic arrhythmias like their electrolytes? What medications are they on? Are they on nodal blockade? You really want to investigate why they're bradycardic. They're bradycardic, asymptomatic, and normotensive. Much less worrisome than the patient that's bradycardic and hypotensive. That patient warrants treatment, and you have treatment being ready to do what you need to do to get their heart rate up to their function. So the way that you treat them, again, is symptomatic. You can treat them medically, so you want to augment them and their heart rate and get them something that can work on hypertrophy or inhibits that parasympathetic system. So atropine is an anticholinergic that you can give in a patient who's bradycardic. Remember we talked about kind of vasovagal and that opposed parasympathetic. When your parasympathetic is working to an overdrive and sympathetic response that you need to have a normal or fast heart rate is impaired. So you can use atropine for those patients. Epinephrine has chronotropy, dopamine has chronotropy, any of the catecholamines. So we've had patients that persistently vagal in the ICU actually give POL, sometimes. As a way to augment hypertrophy in these patients that do that. So we basically just want to supplement something or overdrive, but they have to, we can offer their heart rate. If these medications fail, you need to be prepared to use your patients. This can be done transcutaneously, ouch, or transvenously. And transvenously is through an introducer sheath through some temporary wires. As a way to augment their heart rate until you get the speaker. Transcutaneous spacing can be effective, but it can also fail. Venous spacing can be effective, but it can fail. So you want to get cardiology aware of these patients as soon as possible in case they have a persistent symptomatic bradycardia that could require. Any questions about that so far? Talking about things that cause bradycardia, we're going to go through AV blocks. If you all talked about heart blocks before. Okay, great. So first degree AV block, is it worrisome? Something that you should be concerned about, start getting ready to face? No, it's usually not clinically significant. So this is just a prolongation of your PR interval. It can make your patients relatively bradycardic, but again, it's not usually something that needs to be treated. It's just something to be aware of. Either it can be a normal variance, just something that happens in your patient, or due to increased vagal tone, and then these heart blocks are going to be a quintessential finding for Lyme disease. Lyme can have, as you know, a wide array of symptoms and signs, and this things that cause a heart block. So just for what it's worth, if you have something that's a nodal blocker that's causing this, you can try and remove the affecting agent, treat the Lyme, get rid of your, your digoxin or something else that's causing it. But this is not something that needs to be worried about or be triaging quickly and aggressively. It's just a lot of trouble. A second degree AV block is broken into two types: Novitz type 1 or Winky block, Novitz type 2. Novitz type 1 is Winky block, which is basically the longer drop. The Winky block. But that's where you kind of get this fatigue where your PR interval becomes progressively longer and then you have the drop speed. It's done in a very predictable manner. And in and of itself, similar to a first degree AV block, it's not terribly worrisome. However, patients who have a pre-existing Novitz type 1 can degenerate and develop a more block. So again, this Novitz type 1 is just the fatigue until it's not able to conduct. Again, you may be the cause of this as the clinician with the nodal blocking patients. If they have ischemia, so one of their nodes from an MI, inflammation of the heart muscle process as well. So you basically just want to investigate by making sure there's no concerning like etiology, but otherwise it's required treatment. Type 2 is where you have a constant PR interval, but then you have this kind of unpredictable dropped beat where your P waves are not conducted to the ventricles. Oftentimes you'll see this in a mixed ratio, so 30 minutes freedom line, where you have 3 normal sinus beats and a dropped beat, and then go back into it. Otherwise, it can be a variable block. This is pretty dangerous, actually. Complete heart blocks can cause patients to be extremely bradycardic. It's usually a non-reversible condition, and these patients warrant a government pacemaker. These patients, it's sometimes an etiology for sudden cardiac death, and these patients do progress with their heart blocks frequently. So, a Novitz type 1, again, is a predictable pattern of that drop weight. Due to fatigue, it's usually not symptomatic, it's just symptom variant. This type 2 is where you're starting to see that there's some disease in your conduction system that's not allowing that conductivity to penetrate the ventricles, and that has a high risk of decompensation. So these are patients that need, again, have access and be prepared for Type 1, again, the treatment is identifying these are reversible causes, not clinically significant most of the time, just requiring treatment. Type 2 is dangerous. We talked about it's usually a permanent aberration of the conduction system. You need to be prepared for temporary pacing, and then eventually lead up to pacing for blocks. And then third degree heart block is scary. These are patients where the two chambers of their hearts are just not communicating. The atria are over here firing off, minding their own business. The ventricles are just deciding when they want to go off. There is no organized pattern between atrial and ventricular decarbonization. And because of that, they're usually at that ventricular rate of 20 to 40 beats per minute. So you can kind of see here, you see just these P waves intermittently that are not conducted. And then you have these ventricular beats with that widening QRS here. The perfusing rhythm, these are actually a bit more narrow, so they get a junctional speed rhythm, more ventricular with some pretty wide complex QRSs. These patients are very bradycardic, and again, they need emergent pacing. They're going to be symptomatic, and this is not usually a reversible condition, so they'll get this for this. Any questions about the bradyarrhythmias? So for bradyarrhythmias, we have your sinus bradycardia and we'll talk about some tachyarrhythmias now. And before we talk about treatment, we need to remember our antiarrhythmics if you have antiarrhythmics yet. Yeah, they'll be haunting you. And knowing the common ones, your class one, just remember they go from your sodium channels, clopidogrel, and flecainide are some of the most common ones, lidocaine as well. Procainamide are the ones that you'll see most frequently. Your class two or your beta blockers. Class three, the biggest one that you'll think about is amiodarone, so potassium channel blockades. All right, everybody's favorite AFib. So this is defined as a narrow complex tachyarrhythmia with an irregular rhythm that will forever haunt you as well. That will be consistent in questions that you'll have at some point. And the etiology is that you have multiple foci of irregular rhythm. So we'll talk about atrial flutter after this, which is usually one focus of an abnormal heart rhythm and much more amenable to ablation and other definitive therapies. AFib is a tricky one to really get rid of. And the treatment for AFib really depends on your patient's stability. Some patients are much more affected by AFib than others. Your atrial kick can provide up to 20% of the volume of the ventricle at the end of diastole. So you have patients and you'll hear them talk about, and they're really missing their atrial kick, which means they are symptomatic from this AFib. Maybe they have a normal heart rate, but they're truly missing that augmented return from that atrial kick and just converting them out of their AFib. Patients who have AFib may have underlying cardiopulmonary disease. They may have a history of cardiac surgery, hyperadrenergic states, so that's why you'll see this perioperatively in some patients in the stress response to operation. And then we talk about holiday partner use. So getting a good history, figuring out what's causing this in your patient if it's chronic versus management of AFib. If they are hemodynamically unstable, then we do synchronized cardioversion. We usually pre-medicate with an antiarrhythmic as well, whether that's digoxin or amiodarone. It's helpful to give them that chemical antiarrhythmic as well as electrical to help them stay in sinus rhythm. If they're stable, you don't just want to cardiovert them. Do you know why you don't want to just cardiovert somebody in AFib if they're stable? I can't remember. Okay, if you don't, we're going to talk about it. Sure, so they can evolve into a different heart rhythm. Yeah, what about AFib makes it particularly risky? Okay, good. I can teach you something. So when you have AFib, you have fibrillation or just kind of like quivering in the atria, and in your left atria specifically, or atrium specifically, you have what's called the left atrial appendage. And it's this little thing here on this slide where blood can become really, really stagnant. So it just kind of swirls around in there. And if the atria is not pumping or not squeezing appropriately in the sinus beat, then you can form a little clot there. When you go ahead and shock somebody out of AFib or convert somebody out of AFib, you get this nice atrial kick. That area of the atria contracts and you can have thromboembolic. So the most concerning one that can happen is a patient will have a stroke. Especially if your patient is hemodynamically stable, there is no real convincing reason that you should cardiovert this patient and you should get this patient out of AFib unless you have determined that they, one, have been anticoagulated for a long period of time, or the next not have been. It's obviously still a risk if they're unstable when you cardiovert, but if they're unstable, it's what's going to help save their life, so you can take the risk. But if they're hemodynamically stable, you really want to avoid converting them to CPO. The patient is ways that you can get rate control in AFib are with those nodal acting agents we talked about. So your beta blockers or blockers, the ER really loves using diltiazem for AFib. I would just caution you to make sure that your patient is not underlying heart failure. That can be a negative for them. So any of these agents can slow down that heart rate. Amiodarone can also convert your goal into sinus rhythm. So if that's your goal, that's great. If it's not your goal, maybe some caution with that. beta blockers are usually pretty effective at treating the underlying cause, which for a lot of patients with that hyperactive state. Rhythm control long-term is recommended only in younger patients to prevent what we talked about earlier, which is prevent remodeling. And that's done on an outpatient basis after they've had, monitoring anticoagulation. But for most people, recommendations just to get rhythm control, which is the finding that we're getting. If you have a patient that presents with you onset AFib, and you'd like to get them out of it, then you either get them that TEE to rule out that left atrial appendage, or these patients are put on anticoagulation for about 3 to 4 weeks. Are relatively cardiac. Yes,
Is the atrial appendage always there?
always there. Always there. The clot's not always there. but
I've never heard about that before.
So amiodarone can be used for rate control or rhythm control. But if you have an older person with AFib or somebody you don't want to rhythm control, I wouldn't give them amiodarone.
Yeah, then you would probably stay away from it and you just need a beta blocker. Again, we'll go over some useful algorithms that you utilize to determine who should be anticoagulated for their AFib. And this is particularly helpful because a lot of the trauma that we see now are older patients that fall or on anticoagulation for AFib or another problem and have intracranial bleeding. So there are 2 scoring systems that I would say are used very frequently, and I think are quite helpful. One is your CHA2DS2-VASc score, which we'll go over, that has risk factors for thromboembolic events from your AFib and determines whether or not you should be anticoagulated. But then one of the newer ones that we talk about is called the HAS-blood score. And those are the patients that are at risk for major bleeding if they're based on anticoagulation. So if they're low risk of a clot, if they're CHA2DS2-VASc and they're high risk of a bleed on their HAS-blood, then that's probably something you want to avoid anticoagulation with those scoring systems. When we talk about AFib as well, we don't just talk about the rate. We talk about the chronicity. So your risk of forming a clot in that left atrial appendage is greatest after being in AFib, whether it's paroxysmal, which means in and out of AFib, or persistent AFib for more than 48 hours. So usually within those first 48 hours, if you have somebody that's in and out of AFib and it's certain that it's new onset, those are patients that you can convert with more reassurance that you won't cause a thromboembolic event. It's less than 1% risk of arterial embolism. Versus after that 48 hours, that risk of arterial embolism increases significantly. So we want to be more cautious about converting these patients to a sinus rhythm. And again, if there is no clot, they're going to cause a stroke or acute ischemia. And then you want to evaluate and correct any precipitating factors. So electrolyte derangements are hugely implicated in atrial fibrillation, whether it be hypokalemia, hypomagnesemia, hypophosphatemia. Those are really easy things to correct in your patient that may actually help them convert out of it if there's new onset AFib or help keep them out of it. So post-monitoring and correction is important. And then assessing the cause. So are they neglected and like cardiac dysfunction? Is it something that's needed for them? You will see this in the ER, both new onset and an acute exacerbation or somebody that presents in a rapid rate normally is waiting to relieve of that. So just being able to differentiate, are they stable, unstable, is this chronic? Are they on anticoagulation? I'll sleep them either cardiovert this person or to get them out of their AFib becomes important. But in the ER, the most common decision that you have to make is time pressing is if your patient is stable or unstable. Do you need to get them out of the AFib? Do you need to just read? These are the scoring systems that we talked about. So again, the CHA2DS2-VASc score, it's to do anticoagulate this patient or not, and weighing the risks, benefits, and they are not a number of events. So they have a history of CHF, hypertension, older age, diabetes, a history of prior stroke, or VTE, vascular disease, female, and then they kind of give a range of the points. It used to just be the CHA2DS2 score, and then they expanded upon that to take into consideration gender and age. If you determine that they warrant anticoagulation based on a higher CHA2DS2-VASc score, then that's defined as 2 or above. So they score greater than 2, which you can see is pretty easy to do. Then they recommend anticoagulation. Then you can hop over into your HAS-blood score, which is seeing if the patient's at high risk of having a significant bleeding episode. And Any questions about AFib? Atrial flutter is similar to atrial fibrillation. So again, it's usually one focus of irritability. It has a simply, yeah, go ahead.
What score for the has like typically like?
Yeah, so you have your percentages over here, which is, sorry, I'm not glad this came out so blurry. But bleeds per 100 patients is how they define it. So once you get above 3, you can see that scores of 4 or 5 is a not insignificant amount of those patients. So if you have somebody that's older, has a history of falls, honestly, a history of alcohol use, you don't feel comfortable their head or trauma, and you really want to weigh the risks and benefits. And this is a conversation which you need with patients as well. This is really important for shared decision making and cardiology to weigh it as well. But you really just want to weigh the risks and benefits and inform the patient either way so that they are aware of that as well. And I would definitely say that 3 to 5 rated is not a serious bleeding. So atrial flutter, again, you have this essential sawtooth pattern. It's a single focus of irritability. Like I said earlier, it's usually much more amenable to treatment, so both rate and rhythm control. The sneaky part about it is if it's conducting at a 2-to-1 ratio and the rate's around 150, you may see this sawtooth looking wave, but it may just look like a T wave to you. And so this can look like sinus tachycardia. If the rate's 150 and regular and it's persistent, if you're concerned about atrial flutter, then we'll talk about SVT in a minute, and give them adenosine and identify what for them. But again, this is a much more amenable to intervention that presents a lot like AFib. SVT, sorry, this is kind of a busy slide, is supraventricular tachycardia. So any tachycardia that originates above the ventricles, and it implicates the AV node and kind of this auto-generator of this abnormal pathway. And so what you'll see is what you'll often see is a normal sinus rhythm, and then you lose your P waves to develop this really rapid, regular complex tachycardia. This becomes a problem again because you have this persistent tachycardia. It can become unstable if it's left untreated. And so what you want to do is you want to stop that reentry circuit. So there are a couple of different types, but just keep in mind that you have this reentry circuit that's going through the AV node and causing that tachycardia. So you want to stop that. And one of the medications that you give is adenosine as an AV nodal blockade. So what it'll do, it can be to both diagnostic and therapeutic to create close pause of the AV node. That may convert them back into a sinus rhythm, or it may show you what else is a supraventricular tachycardia, atrial fibrillation, atrial flutter. So what arrhythmia is underlying that sets up the SVT? Adenosine, has anybody seen someone get adenosine? People hate it, you stop their heart for a second. So good expectant patient management is important. You want to have them hooked up to a cardiac monitor and have them working drugs nearby. Oftentimes, nothing bad happens except the patient feels pretty awful and everybody gets nervous during the pause. If they are unresponsive to a dose of 6 milligrams, you can give 12 milligrams about a minute or 2 later. If a patient is unstable, the theme of all of this is an unstable rhythm, then you can go ahead and cardio alert. And then these patients will get catheter ablation because this is uterine sites. The most common populations, these are usually in young patients, and young female patients have SVT episodes more often than other patients, and sometimes they'll know that something works for them. So either they're on a nodal blockade that works for them that they just need more of, or I had a patient before that goes, "So really like this." They say that I'm the only patient that really does this, and she begged for herself and broke out of her SVT and thought it was the coolest thing that works for her every time. I was like, "Good for you." But they'll know. So you can have them attempt to think, well, oftentimes it doesn't work, but for some patients it does. So actually talking to your patient, getting a history, can avoid them from going down a really painful pathway. If it's something as simple as just. And then eventually, again, cardiology can provide information if this is persistent, symptomatic, or current. I think we're going to see more of this, honestly, in practice because of Apple Watches. We've already seen people coming in just saying if they're getting alerts that either their heart rhythm's abnormal, you know, you can detect AFib now, and then tachyarrhythmias. They get warnings for that too. So we've had a couple people come in because their Apple Watch keeps them in. So we'll see. It's kind of cool. We're talking about these reentrant tachycardias or SVT. There's an important variant to know about called wave heavens light. Are you all familiar with that at all? See some nods. Okay, we'll go over it. What it is, it's an accessory pathway to the bundle of intent. And it causes this kind of classic upsloping of the QRS complex called a delta wave. This is important because this accessory pathway bypasses that control of the ABP node. So when they become tachycardic, they just stay tachycardic because they're in this accessory pathway. You'll see this delta wave, and it's important because as opposed to the other tachyarrhythmias, you want to be very careful and not give them AV nodal blockade, because if there's any chance of that AV node slowing down their tachyarrhythmia, you have basically just stopped your defense and allowed them to run wild. So this accessory pathway just keeps perpetuating and it now has no check. So because of that, you want to give sodium channel blockers that don't work specifically and avoid those other antiarrhythmics like beta blockers that will block your defense of the AV node and propagate this reentrant to do this abnormal pathway that kind of, I don't have a good picture of it, but basically just all over the bundle of this that allowed to go unchecked and cause really dangerous arrhythmias in patients. Those are your neurocomplexes. The bradycardia is a sinus bradycardia, and then your heart blocks and ventricular tachycardia includes SVT, AFib, flutter. Thanks for talking about those real far. All right, get into the fun. All right, why complex tachyarrhythmias are dangerous tachyarrhythmias? Not that the neurocomplexes aren't, but these are tachyarrhythmias that cause patients to arrest. So if you think about ACLS, they'll go down for ACLS algorithm for these. You'll see a wide QRS because the origin of the impulse is the ventricles. And normal when you have these ventricular rhythms, they'll be suppressed by your SVT as they are AV node. But this is when they are not suppressed and they become the predominant rhythm of your heart. And unfortunately, these can just get very severe. So the first one we'll talk about is ventricular tachycardia. That can be monomorphic or polymorphic. Monomorphic just meaning that each of the beats look exactly the same. They're identical, defined as your premature ventricular complexes. They're just these abnormal ventricular beats we'll talk about. If there are 3 or more sustained, it's called VT, and again has that wide QRS complex. These patients surprisingly can be hemodynamically stable. So you can have a patient in VTAC that's producing. It's just not guaranteed that they're going to stay that way. So you definitely want to get them out of VTAC as soon as possible. And you can attempt antiarrhythmics if they're hemodynamically stable. So amiodarone is a really good one for VTAC. Again, being prepared, they may become hemodynamically unstable. So I usually have a crash cart nearby, maybe pads already on the patient in case they're not responding to medications that deteriorate and lose their cardiac output. If they're hypotensive but have not arrested, so this is VT that is symptomatic and clinically significant, then you want to do a synchronized cardio. So still cardioverting, still using electricity, but you can synchronize the output. If they're in cardiac arrest, you do defibrillate. So that's at 200 joules. You shock that patient, get them back. Their cardiac arrest and follow your ACLS algorithms. And then you want to correct any electrolyte abnormalities you got. In someone that's in sustained VT and they're really hard to get out of, oftentimes we take patients out of the equation. So we sedate them, we intubate them, we remove any kind of like external exciting stimulus and really work on loading them with medications that are antiarrhythmics. So you really, those patients will be admitted to the CCU and aggressively managed there. But again, they can range, it's kind of disarming because they can range from hemodynamically stable VT, which is always a very unforgiving situation, to hypotensive to cardiac arrest. So treat them when they have it and be prepared for them. Polymorphic VTAC is again the tachyarrhythmia with arising from the ventricles, but now your complexes look different. And you have a special case of polymorphic VTAC there. Yeah, torsade. And then you know it's torsade. Yeah, I see a lot of pens going in there. You have your twisting around the baseline bit here. So this one's a bit hard to tell. This was just one that we captured in our ICU, so I liked it. You can see that it kind of looks almost like a DNA complex of this twisting around the general baseline plate. SODS or VT, sometimes it's caused by what's called an R on T phenomenon, which is that you have depolarization during repolarization, and it just ends with so that's what this showed us here, actually. She, during repolarization, tried to depolarize, and it set off this, it selected out this first SOD. She was somebody that needed the RCA MRI. For polymorphic VT, we manage it the same way as monomorphic VTAC, except for this patient. I cannot think of an exception where they were not depressed. So it's very rare to have somebody that's in polymorphic VTAC with a pulse. I have not seen everything that can happen, but these patients will follow their ACLS algorithm. In torsades, it's usually propagated, we talk about this R on T phenomenon, it's also propagated by a long QT. So amiodarone is not helpful in this patient population because amiodarone is a QT prolongation. Often what's underlying this is an irritable myocardium and hypomagnesemia. So having a low magnesium is implicated because magnesium is a smooth muscle stabilization, prolactin, and that myocardial stabilization electrolyte. So if that's low, even if it's normal, if you see something in torsades, give them 2 to 4 grams. Doesn't really matter what their level is, but give them something, you can repeat that as well. So avoid your QTC prolonging agents, shock them, and give them magnesium. They're going to be the 3 things that and they usually come out of it quite nicely when you do that. But again, sometimes it's hard to tell when they're going so fast, and all of a sudden you just see polymorphic VT on the computer or on the telemetry. And I've had patients that were inappropriately kind of bolus amiodarone over and over because they were just treating the VT. And unfortunately, that's just adding to the problem. So avoid those QT prolonging agents, give them and then shock them. VFib is a terminal arrhythmia. So this is when your ventricles are quivering, with no outlet. You have no discernible waves. You just see a bunch of static around the isoelectric line. And the most common cause is ischemic heart disease. So VFib is a really awful rhythm. You have to defibrillate and follow your ACLS algorithm, but usually it means that there's some pretty serious coronary ischemia and cardiac problems that may or may not be recoverable. So once you put someone's deteriorated into VFib, it's a very rare sign for them. And that's what it looks like. It looks like just a bunch of noise. There's no discernible wave. It's just like the range of ventricles. If you get them out of this stage is going to need a reactive defibrillator to prevent you from Yes.
Sorry, can we go back to torsades just for a second? So amiodarone's bolded, but you said don't give them amiodarone?
Yeah, sorry. So polymorphic VT, you can. I should have had a separate slide to differentiate.
That's okay.
But in torsades specifically, which is a subtype of polymorphic VT, then you want to avoid.
Okay.
So for normal VT, whether it's monomorphic or polymorphic, in general, you'll get amiodarone. However, if you identify that it has this torsades pattern, being more suspicious of its QTC prolongation, give them that.
Thank you.
And then you also said that if stable is almost never true.
I included it because it's what the textbook said, but
We apply the cardio.
you'll be defibrillating. Yeah.
Oh, because they do that.
Yeah. Yeah, monomorphic VT, I would say more commonly you can see a patient that's actually, for whatever reason, is able to mount with adequate cardiac output and it's stable. Polymorphic VT, I haven't seen that. And then there are ectopic feeds, so things that don't fit quite as nicely in these categories. So PACs are just premature atrial complexes. They arise from the atria rather than your SA node. They again don't require treatment in and of themselves, but they may be symptomatic of something else, like an electrolyte imbalance, substance, hypoxia, or stress. PVCs are similar. However, if there are multiple PVCs in a row, we talk about 3 or more, that's defined as VT, whether it's sustained or not. And multiple PVCs, especially in patients with underlying heart disease, may put them at higher risk for arrhythmias. So those warrant rapid correction. Multifocal atrial tachycardia is clinically significant in the sense that it's a sign that you have poor pulmonary disease. There's not a lot to do with it except for treat the underlying pulmonary disease. It's defined as 3 or more P-wave morphologies and heart rate greater. If it's less than 100, it's called a long-term pacemaker. Include it in here. It's a very common test question. For whatever reason. There's not a lot to do with it. The other than treat them. Question not. Break number 2. We're still almost on time. We're on 5 or 10 minutes. 5 to 5. Yeah, or 7, whatever it is. Not good. Time out there. We're gonna talk heart failure, valvular emergencies, cardiomyopathy, cardiomyopathy, VTE, and CTE. So again, a lot of these are familiar, so we'll just go through quickly about the diagnosis and heart failure is going to be first. We define heart failure as a chronic condition in which the heart muscle is unable to pump enough blood to meet the body's needs. And again, you can have chronic heart failure, and then you can have acute exacerbation or like heart failure. You can also have acute heart failure. Patients with heart failure actually usually present with some pretty essential symptoms, so shortness of breath, peripheral edema, and fatigue. This can, again, either be from structural cardiac damage or just changes over time due to ischemic or non-ischemic pathologies. And then the pathophysiology, I know that we've spoken about this before, is that your cardiac output is low, so then your body tries to help out by activating your RAS system, which causes you to retain water, increase your systemic vascular resistance, making it once again harder for your heart to work. So your heart's trying to augment your blood supply and your perfusion to your vital organs, but unfortunately it kind of feeds into this vicious cycle of and increasing that myocardial. Natriuretic peptides are the body's response to try and combat this increase in volume overload. So again, the body's just kind of fighting itself. It's low cardiac output, activation of the RAS system, retention of water, vasoconstriction, and then, oh crap, we have too much volume. All of our baroreceptors are our preload's too high. We're volume overloaded. So like releasing natriuretic peptides and try and get rid of some of this volume. Natriuresis, get rid of sodium. And that's why we monitor BNP levels in heart failure. Tell you the trajectory of that patient if you know their baseline and know it's increased for them. Natriuretic peptides again are going to try and combat that compensatory response that now is too much for the heart to vasodilate and RAS system. So it's this vicious cycle. Heart failure is very, very hard once their patients kind of fall outside of that cycle in the sense that they are no longer using their heart failure is getting worse. We'll talk about kind of the management and diagnosis. Remember that it's defined as 2 types, but most people have both when they're presenting with heart failure symptoms. So systolic dysfunction is when you have a decreased ejection fraction. And you can imagine if these patients aren't able to breathe well, they aren't able to get that forward flow, they're very sensitive to acid. So they're not going to tolerate hypertension. They're not going to tolerate. It's going to worsen their EF. As opposed to diastolic dysfunction, diastole is when your myocardium gets to relax and fill, which is going to be a normal EF, but you have a smaller gene burst, smaller filling, so they're going to be very sensitive to pain. So you want to make sure that they're usually function, again, is more associated with those symptoms that we talked about, of the shortness of breath, the fatigue, and the peripheral edema, whereas diastolic dysfunction can be relatively asymptomatic, is being diagnosed more in the most common cause of diastolic dysfunction is hypertension. That causes the LV hypertrophy. Diastolic dysfunction can also be caused by cardiomyopathy, which we'll talk about a little bit. So hypertrophic cardiomyopathy, and again, you want to avoid hypertrophy at increased preload patients. And right heart failure and left heart failure, we know that this does not usually exist in isolation as a system. So you have the right part of the pulmonary system, the left part. So when one starts failing, there's too much afterload, it kind of So acute decompensated heart failure, it can be one of two things. Either your patient already has underlying heart failure, they were in their normal heart failure homeostasis, able to live their life, something difficult to catch. That can be something like an arrhythmia, an infection, or something that increases the workload of your heart. Or any of the things that are listed above, so myocardial infarction, it can also be lifestyle choices. Maybe your patient is being very good about taking medication, so diet and monitoring fluids, and then they kind of decided to let loose. They were feeling better, so they skipped a couple days or Lasix, or they had difficulty with access to their medication and their financial pressure. And new onset heart failure, people they want to do a thorough investigation. These are time sensitive. Your body has not had the time to accommodate this disruption in cardiac output. And those patients get sick just quickly and usually have very intense survive. So again, heart attack, myocarditis, any valvular dysfunction, those are things that you want to identify. So what do you do with these patients when they come into the ER? Again, you're assessing their stability and then you're getting a better history because it's going to be managed. So do they have a history of heart failure? So now you're thinking about what to do over the edge and start asking questions about medication access, lifestyle choices, and then any other symptoms that would suggest infection or disease. Is it somebody that has a history of renal failure? So they maybe miss dialysis and their volume overloaded. We see this not infrequently from patients from underserved populations that have difficulty getting to and from dialysis. If they're feeling okay, sometimes they'll miss because they don't have the patient or they can't do this right organs. Unfortunately, they end up needing to emergency with frank volume overload. Substance abuse. So if they're doing anything that kind of increases their heart rate or their cardiac output, like cocaine, meth, alcohol abuse, that's going to exacerbate underlying heart failure or prostate heart failure. And then what do we do to patients? Have we messed up their regimen? Have we given them too much or too little of a medication? So did we give you a calcium channel blocker when you didn't know you got heart failure? Oh no, now we've really exacerbated your heart failure. Have we given you some NSAIDs or some steroids or something that makes you retain salt and water? Did we think you were doing better than you were doing and we decreased your medication appropriately and now you're bouncing back symptoms? And again, just those, I think most commonly we see either decrease or initiation of steroids. On your exam, you're going to see some signs of heart failure if it's chronic, not if it's acute. So you may see that peripheral edema, your rails on your volume. You may have some JVD. You may be able to help me to figure out congestion. And then you're in oxidative S3. Part of the workup, though, is you're going to start taking some labs on that. We'll talk about that next year. EKG, and why do you want an EKG? Think they're having a heart attack. Yeah. In case they're in an arrhythmia, why are they experiencing heart failure? EKG can help you with this. A chest X-ray. What's helpful about a chest X-ray? Really? Yeah. I love that answer. So you see an enlarged cardiac silhouette or small, that's showing you the difficult chronically start. You have increased cardiovascular emergencies, so it's really being lines that we talked about. A DNP, again, if it's high, you don't have a baseline, that's not helpful. It can suggest that you're having underlying heart failure, but especially if they're in your system and you have the labs and you see what their DNP is trended, then it's nice to know that if it's much, much higher, yes, this is consistent with people exhaustion. And then focus. So bedside ultrasound is becoming very, very widely used under EM Pulse for the first one that we did. It's very much very quickly assess valvular puncture dysfunction, either presence of pericardial effusion, even like your dissecting flaps. It's very, very useful in specific 5 minutes, if that, to assess your cardiac function. As you get more practice in when you're actually in your clinical arenas, if this is really. And if you can't do it, or if you don't have a good machine, or you're unfamiliar. So what do you do about it? It depends on what's happening with the patients, like everything else on acuity. So if your patient's unstable, address your ABCs. Make sure that these patients are on cardiac monitoring, have IV access. And then the decision of whether to admit this patient versus observe them depends on how they respond to treatment. So is this somebody that, again, just had a kind of free-for-all weekend, maybe missed some medication, takes a little bit of diuresis, and can go home, versus someone that may have another underlying etiology as to why their heart failure or something. So you want to supplement their oxygenation if they're hypoxic. These are patients that we talked about this before, similar to COPD patients that evidence shows that they benefit from if they're hypertensive, what do you think is going to happen to all of the fluid that you normally get out of your left heart? Back up, where are you back up to? Yeah, extremities, but before you get there, so you've gone left side and you're going backwards. Lungs. Yeah, exactly. So you can go into what's called flash pulmonary edema, which is where you're acutely hypertensive, you drop your cardiac output, and all of that lovely oxygenated blood that's supposed to go to your body is now patients. Look at their x-rays, it's bilateral, really significant. And maybe rapid diuresis, vasodilation. If they are in shock, we've talked about treating cardiogenic shock before. What are some things you can do to help them? So I like that answer. What you can do to offload are things like ionometers. So medications that help the heart escape, as well as decrease your oxygen, like using inotropic agent, companies with dilation. Those you get to with that. And then diuresis. Again, these patients are really sensitive to preload and not able to move the volume. So if they're hypervolemic, getting volume off of them can actually help. A lot of people are understandably nervous to do this when somebody's in cardiogenic shock. They think that they're going to lose their vision. Oftentimes, you actually see the opposite. Their blood pressure is higher because those that right ventricle, that people are so stretched that they cannot augment to fix this solid. Augments the cardiac activity itself, decrease your afterload, and help minimize. The evaluation, we talked about EKG, looking for etiologies that could cause that to have decompensated heart failure. The X-ray to look at both the lung parenchyma as well as their cardiac silhouettes. You can get a blood gas if they're tachypneic and you're worried about their oxygenation, if it's going to help guide your decision making. I don't know that it does in the very acute assessment management. The echo, whether that's your own focus echo, but also go a lot of cardiogram. And then if you're concerned that this is an ischemic event or ACS, that getting them to cardiac cath, where either they may or may not utilize the treatment, as we've spoken about, diuretics. Yeah, these patients are usually falling up, or the preload is way too high. Maybe falling off, non-invasive positive pressure, and then those intubation. Sometimes your patients do need intubation. I would just caution that they're changing intrathoracic pressure, as we talked about, and then the vasodilation. To be pretty catastrophic for a patient for severe vascular. Usually non-invasive positive. And then down the line, not necessarily in that, and these patients may need solution. Any questions about heart failure? Again, you've had this a bunch of times, and I will just encourage valvular diseases. There's nothing more fun than trying to medically manage surgical problems, so let's talk about it. The first one and probably the most common valvular disease that you'll encounter, so it's a disease that becomes more prevalent in our population, is aortic stenosis. So this is, you can see here, with a normal aortic valve when open, has a nice open movement, closed, it approximates appropriately. However, when you have all of this calcification, when it opens, the lumen is changed much more limited for your blood flow, and then if you close, you have this alteration in architecture. And so these patients have a really hard time. They may have severe aortic stenosis and be able to live their life okay. And similar to heart failure, something happens where they need increased cardiac output and they can't output. And these patients get sick. So they may present to you with dyspnea, chest pain, sympathy. Again, because you can imagine you have an increased workload of the heart, you have increased demand from the body, then when you're trying to squeak the blood through this stenotic valve, patients are hard. They do not tolerate tough urine as well at all. Because again, they're filling this garbage, and then they can't adequately operate. Right, so epilepsy. So these patients also oftentimes need pouring off. However, it's a little bit of a dance because you can see that they also, their valve doesn't close very well, and doesn't open very well. And so if you drop their reload too much with their hypovolemic, then that little bit that they're able to squeeze through that valve then drops precipitously as well. So in general, it's helpful to get volume off, but just be very cautious with their volume. Because these valves are again, decreasing your afterload theoretically should be nice because it should offload the workload and try and get through that tight valve. But again, it can drop your preload, and if you're relatively hypovolemic, drop your preload, you've already cut it to optimize your volume. Then you're going to want to. You want to keep them nice and relaxed because they're not able to compensate for increases in activity, and then we need cardiology and cardiac surgery. If they are a candidate for open heart surgery, then they may be evaluated for that. That's a big surgery for a lot of these morbidity, in which case they can do what's called a transcatheter aortic valve replacement. They just do that case approach to the body. Much less morbidity associated with that.
Sorry, why wouldn't they do this all the time then if there's less risk associated with it?
Because it doesn't have the longitudinal.
Okay.
It's more of a short-lived approach. Okay. So similar to like tissue versus mechanical valve replacement. Mechanical valves go a lot more time before the infection. TAVRs only have a certain lifespan that's much shorter than the actual valve.
Okay.
And so it's good in the older sick population, but in your younger patient, that will be fixed long-term over decades.
Okay.
So, and just keep in mind these valvular problems we're talking about, but also keep it in mind for your patients. It becomes some pretty significant consideration for anesthesia. Aortic regurgitation is the opposite problem. So it's the incompetence of the valve closes, it causes again back up into the right side of the system. So cardiogenic shocks and dyspnea. And this can happen for a couple of reasons. The two most common are going to be aortic dissection and endocarditis. Got an echo, and then again, something from cardiac surgery assessment. This has a pretty nice quintessential murmur, so it's a flowing diastolic murmur. I heard in the left lower sternal murmur. So if you hear that in this question, that's pretty common for courage. They have a wide impulse pressure of what's called a water pulse, which means like they have this pulse that has a quick rise and it's upstroke and then stops it. Quick rise and upstroke and then stops it. So any of those things we have to again, tachycardia is how your heart's going to try and augment this poor cardiac output, but again, it's just kind of these vicious cycle for filling the output. And this is very much surgically addressed in this case. Two things to be thinking about when these patients can see the or what's causing it dissection. Again, it's going to depend on how sick your patient is and how acute, but this is a cervical problem. It gets chronic and these patients are, you manage their afterlife, so basically trying to manage their afterlife with these inhibitors are. Mitral stenosis, is infrequent here in the United States because the most common cause is rheumatic heart disease. It can also be congenital or just calcified valve degeneration. Again, this is the left side of problems are mitral valves. So things that cause your left side not to work cause dyspnea, and they may have hemoptysis. That's from like very, very extreme periods of time. The treatment for this is symptom control. So again, you want to decrease your afterload, anticoagulation. For these, I would say from a board standpoint, just know the discretion. They're usually in the same discussion of what makes the murmur voice better. What it sounds like. I remember from however many years ago. Hyperregurg is a pretty scary problem. So this is often seen after an MI, again, due to capillary muscle rupture that we talked about in the CS portion of this lecture. So this is when you have a leaflet that doesn't proximate the other leaflets and causes severe dyspnea, tachycardia, and rapid onset. Are 666 because their cardiac output is awful and their lungs are just frankly counting. We had a patient and did a bronchoscopy and we took a liter of fluid out. And it is really, really significant that hydrostatic pressure in the lung. It needs rapid surgical. You treat them as cardiogenic shocks, and you decrease that afterload, try and help out those lungs and get blood pump. It's an MI, that revascularization, but oftentimes this is after the MI. If it's chronic and mild, that's one thing. The acute mitral regurg is getting them with condition like this is physiotechnology as well. Other causes other than MI to think about endocarditis for chronic are some things like rheumatic heart disease, and then connective tissue disorders. And then prostatic valve disease, the patients that have had valve replacements that come in with disease, whether it's decalcification, infections, and endocarditis. Unfortunately, a lot of things can happen. They can have thrombotic events, dehiscence of the suture lines with the valves, that you can get a what's called a perivalvular leak that causes incompetence of that valve and degeneration. Again, more commonly with tissue valves and mechanical valves, better time. And then they may come in with complications of a supertherapy device. So patients that are on chronic anticoagulation for valves, just because be aware that you should assess their anticoagulation status so you get a kind of or anything new in there that didn't sound familiar. Know what those numbers are. Cardiomyopathy is a disease of the heart muscle itself that alters its function. And there are three types: dilated, restrictive, and hypertrophic. We'll talk about dilated first. This is ventricular remodeling that happens over time that causes signs and symptoms of heart failure. And if your heart has such a poor EF and is so dilated that blood doesn't move out adequately, you may have that stagnation, like we talked about in the left atrial appendage, and they can develop LV thrombi and ischemic complications. So these patients may need to be on anticoagulation. The diagnosis is echocardiogram. And the etiology, so alcohol abuse is one of the most common causes of dilated cardiomyopathy, pericardium, any kind of chronic high output failure, so heavy competing drug use, myocarditis, stress cardiomyopathy or pseudo cardiomyopathy, we all heard of that. And then connective tissue disease as well. They may have, again, they're gonna have signs and symptoms of left-sided heart failure. It requires support, just like we would for a. You can see there's that disrupted architecture of that dilated ventricle, and you can see there are these little kind of pseudo chambers that are developed here, where blood can be stagnant. The most common place that moves a lot of this is right here at the apex. And again, that's diagnosed by echo, but they may present with acute arterial occlusion. And then we have dilated balloon heart. So treat like heart failure, with after liver reduction, beta blockers, they can be referred for transplant evaluation. And then because of this disruption and irritability in their architecture, they're high risk for, so these. Myocarditis, we heard a lot about this from the COVID vaccine, COVID itself, but it's inflammation of the heart muscle itself. Most common, if you're asked on the board question, is coxsackie virus, but again, it's not very good. It can be caused by any viral infection, like hepatitis. Bacterial infections can cause it less frequently, and this is those spirochetes or Lyme or cortisol or something infections can cause it as well as autoimmune disease. So a lot of etiologies of most common is viral. It's a direct inflammatory response to the infection that causes these patients will be sick. They present oftentimes with cardiogenic shock. They're fragile, and you may appreciate a friction rub and rel. They'll have elevated cardiac enzymes as well, which is interesting because many times they're going out other causes of heart failure. It can look a little bit confusing, but the fever is something that has to be off beyond the age of the viral prodrome. The gold standard for diagnosis is a biopsy, but it's almost never done if you have a high index suspicion to rule other things out. That's how you want to definitively diagnose carditis, and it's mainly supportive care. There's not much that you can do for this. There's a special case when specifically kiddos with Kawasaki disease and that you treat with IVIG and aspirin. Imagine that. And then hypertrophic cardiomyopathy. You all heard about this, you have it, right? This is when athletes suddenly die, unfortunately. So it's a hypertrophic change to your septum here that, as you can see, there's your LV outflow tract. And so what'll happen is that somebody will be doing just fine, and anything that needs to increase your cardiac output can cause sudden loss of that cardiac output and death. So it's an autosomal dominant disorder, so it's inherited. So this is why we ask about things like what runs in your family. Does anybody in your family develop sudden cardiac death? It's relatively uncommon, but it usually makes the news again. These are high function individuals from an athletic standpoint, but unfortunately don't know that. So they developed signs from impaired diastolic relaxation and increase in your LV blood pressure, so that they may be just fine until they have that increased demand. That's what's pretty scary about it. The most quintessential symptom for this is exertional syncope. So again, as they're trying to increase their cardiac output, that changes phases and they're not able to do so. Again, the changes in these murmurs very, very helpful in for history taking, but also for exam. There's a lot of this. So shortness of breath, dyspnea, exertion, chest pain, palpitations, decreased exercise tolerance. These are usually young patients, again, have that family history, perhaps of sudden death or drowning, something where they're exerting themselves and can't have that cardiac output. And you can diagnose this by empathy, right? And you'll see that using that for itself. The treatment, it's hard because you're trying to tell somebody to slow down and not do the things that they probably think to do. Beta block them, because you can imagine if you're tachycardic and you're not feeling that LV, that what was spurting through that LV outflow tract is no longer happening. So beta blockers are the mainstay of treatment. And then they need to be referred to a cardiac surgeon because they can do surgical intervention either with alcohol or just people think of that. Prescriptive cardiomyopathy is a really terrible disease. It's where because diastolic dysfunction is cardiac failure. So that's shortness of breath, fatigue, a lot of respiratory complaints. Again, diagnosis is via echo. It's kind of global hypokinesis, and a big LV for kind of problem. It's caused a lot of time by autoimmune conditions, specifically sarcoid or hemochromatosis. So you treat the heart failure, and then these patients need to be evaluated for heart transplant. It's pretty awful when they become symptomatic from this. And it's a really difficult process for them. Frequent readmissions for pulmonary complaints. And you're just trying to manage them as heart failure without a good exit strategy other than transplant. Pericarditis we've talked about, so I won't go over. This is just again emphasize that with pericarditis when you're evaluating HE, you have this diffuse ST segment patient that you can see without reciprocal changes. History. So knowing the patient history is important. I think this is more reassuring. We had a patient with this recently who had new onset AFib after a blunt injury to the chest. And when we got in CPG, it looked almost exactly like this, and it's just reassuring that it's just irritable after one with the injury to the blood that went in the pericardium. But you want to still assess these patients, make sure there are no changes that are concerning for a implant. Again, you're showing these things that we talked about, the PR depression, the widespread ST elevation. We talked about concave versus convex. So as opposed to a semi, which oftentimes has that too, so if you're in this is a nice upsloping ST segment, so more reassuring. And then the only reciprocal ST depression that you may see in pericarditis should be in AVR or V1. It should be the only place that you see reciprocal depressions. Otherwise, we more concerned with CCS. The treatment for pericarditis, it's just symptomatic treatment. There's not much that you can do for it. And then just monitor for effusion development, because oftentimes it's appeared to be from fluid surrounding the heart. We use purchasing and NSAIDs for this as well. Just again, things that are irritable to the heart or anywhere else will cause inflammation and relevant fluids, and just monitoring for that pericardial effusion. Developed tamponade we also very many times. Go straight to the EKG. So things that you may see in tamponade are this alternance of that living QRS complex due to the surrounding volume. So that's the thing we could talk about with tamponade. But you know those patients may present in shock. You need to give them volume to overcome their inability to develop effusion. And then DVTs, have you been over DVTs? Too much? A little bit? Okay. All right. They're important in emergency medicine world because they're an important donor because DVTs can lead to PEs and with life-threatening situations. So that's why we kind of really for DVTs and making sure that you know what's happening. So risk factors, any hypercoagulable state, common signs of pain in the calf with dorsal flexion of the foot, know what that is and how you elicit it. And then lower extremity pain, swelling, cramping, or localized therapy. Lymphasia is when you have a DVT that's causing such significant obstruction to the venous return. You get ischemic complications to your leg. So they'll appear in models of vascular surgery consults that needs to happen. Lymphasia can be serious. So they become swollen, painful, blue, or frankly pallor red with a big venous thrombosis. And so anticoagulation and then getting vascular surgery involved. We talk about DVT leading to PE, so you can use Wells criteria to put another kind of risk stratification and tell you how likely it is that a patient has a PE. If it's a low to intermediate pretest probability, you get a D-dimer. If it's higher moderate, get the ultrasound assessed for a DVT. If the DVT is present, excuse me, I said PE, I should say DVT. If a DVT is present, you treat it. If it's elevated D-dimer, then you want to refer those individuals to follow up in a week for a repeat scan. Maybe it was something that when we would be seen on your lower extremity duplex, and they're high risk with a convincing physical exam and an elevated D-dimer, which is a micro of the hybrid degradation products. So you know that there's going to be a toxic type. You can treat them with Lovenox and heparin. Treat them with Coumadin, which most patients don't like. And then Lymphasia, again, you want to treat them as we would with an ischemia, get vascular surgery involved, and then watch out for questions on these? Do you feel like you need to go over them again, or should I move on? Move on. You want to take like 2 minutes on these again? All right, PEs worrisome because they can cause a shock. The instruction and the pulmonary circulation. Patients can be asymptomatic or indiscriminate, so just knowing how to treat the patients accordingly, and its recognition of the treatment. Your risk factors are any hydrocoagulable state, acting with CTOs, personal or family history of hypercoagulability, and then anything that makes you a risk for IPT. You can also have pulmonary emboli that are not related to blood clotting. They can be air paths or amniotic fluid water. The most common sign and symptom are tachypnea and dyspnea. These patients may also have egoship pain. It's usually with inspiration and expiration, palpitations and anxiety, hemoptysis, and then in your submassive PEs, sure those that don't cause hemodynamic compromise but are enough to cause an obstruction that's symptomatic and causing endocrine dysfunction. Presyncope or syncope is actually not. There are a lot of good meta-analyses that show that throughout the spectrum of PEs, syncope is a pretty common symptom. And that's usually when they decide to seek treatment. The diagnosis, the gold standard is going to be your CTPA. EQ scans can be used if you have a low suspicion and you have a patient with comorbidities like renal dysfunction and AQ apprehensive about getting cardiovascular. If you truly suspect it's a PE, go ahead and get the CTPA. You want that CTA to demonstrate that a PE is so that people will treat it. A DQ scan just looks at differences in filtration and perfusion. It can happen for a multitude of reasons. So even in practice, even if your patient is pregnant, has underlying renal dysfunction, if you are concerned about a clinic place, please get the correct imaging to treat appropriately. EKG, the most common is sinus tachycardia, but you will see this happen when it has 1, 2, 3, 2, 3. Is that S wave in wave 1, a Q wave, and an inverted T wave in wave 3. So if you see that in the question, you should answer. Get a duplex on your patients, find out where the DVT is, what's causing your PE, and then echo. Again, echo is really important. Does anybody remember what the common sign is?
We can see it. Isn't it like you can see it kind of
I like the spiral.
it like flips around? Like you can see the clot move. Did that work?
Not quite. So McConnell sign is going to be a sign of RV strain where you'll see pretty poor motion of that lateral wall, but then really hyperkinesis of the apex. And that's because your apex is tied to your LV on the right side. And so where the obstruction is causing RV dysfunction, that lateral wall can't move. And you'll see a little bit more of the apex. And so that's what you see. There's a tiny grain here. And so this is your normal RV and diastole, but then you're having that systolic contraction. The free wall can't move because of that high afterload from the blood clot pulmonary system. But that apex, you can see it's linked to that LV, and so you get this hyperkinesis of the apex. And that's pathognomonic for the PE, and a really good way to assess for that. Chest X-ray findings. This is in chronic PEs where you've had infarct to your pulmonary tissue. So Hampton lump, which is your wedge-shaped infarct, and Mark sign, which is the decreased vascularity. Both are very subtle and neither I find very helpful in real practice, but they're there. So then you have Wells criteria for the probability of a PE, and that's your little saying to help you remember. Don't die until the team calculate criteria. So DVT, PE being the most likely diagnosis, are tachycardic. They have immobilization or surgery in the past 3 days or 30 days. Have they had a VTE in the past? Do they have hemoptysis or cancer? So just looking at those hypercoagulability factors. Keep in mind, we've talked about this before, the size of the clot is not what makes you say it's clinically massive or submassive, it's the patient response to the clot. So you may have 2 patients that have the same exact thing, which is this giant, what's called a saddle PE, which is where it goes across your main pulmonary artery trunk, your bilateral pulmonary artery branches. And that Billy defect right there, that big old black line is a giant clot. You may have 1 patient with this image that is completely hemodynamically unstable, and you may have 1 patient that has its cardiac arrest. And it's all about their RV's ability to compensate that obstruction. When we talk about treatment, all patients get anticoagulated. if they're systemically ill, so those high-risk submassives that have organ malperfusion or the massive hypertensive patients or MS patients, if there are no contraindications, they can get thrombolytic therapy. For long-term prevention, if patients can't tolerate anticoagulation, they can get IVC filter, which sits in the IVC and acts as a net to catch blood clots that may propagate to upstream. Keep in mind that doesn't help you treat the existing clots. They can still have increasing clot propagation distal to the IVC filter. Thrombectomy, so either interventional radiology or vascular surgery can go in and take out the clots. They're usually nervous because passing wires through a big injury RV can be a risky situation, propagating bad ideas and decompensation. So we actually, our center uses a pretty good amount of knowledge and cardiac support with these patients. So they're having passive and then investigate the cause, so you know, anxiety. In their initial medical management, a lot of textbooks and a lot of practice will say if they're hypotensive, give a lot of fluids, but keep in mind, you know a bit better now that the reason that they're hypotensive most of the time is because they're in right-sided heart failure, and that if they're hypervolemic, that's actually going to worsen heart failure. So be cautious with giving fluids. I'm not saying absolutely don't do it. Don't just automatically do the giant, you know, liters of fluid bowls because they're hypotensive. They may just need some inotropic support. And then support their oxygenation. Again, caution with intubation and acute right heart failure, that hypotension with induction, and then the changes in intrathoracic pressure with intubation and full ventilation can be deadly for your patient. So if they need to be intubated, they need to be intubated. But think hard before you do it, because it's pretty dangerous for these patients that are very sick from their disease. This is another algorithm that we talked about last time. We talked about PEs based on the probability of information and whether or not they have organ dysfunction. So again, just kind of plotting down if it's segmental and more peripheral PEs with normal end organ function, the RV is okay, then you can just anticoagulate or give an IVC filter. If there's RV dysfunction, then you need to consider more invasive and aggressive treatment for that PE to relieve the risk. Any questions about these? All right, last little bit is hypertensive emergency and urgency. You've spoken about this before, right? Or you've heard about this before? Okay, good. So hypertensive crisis is just that defined just by the hypertension itself. This is called greater than 180 or diastolic blood pressure greater than 110. If there is no end organ dysfunction, so by that I mean your patient's not having a stroke, they're not showing evidence of an AKI, they're not altered, then this is a hypertensive emergency. If they're symptomatic in those end organ diseases, then it's considered a hypertensive emergency. That becomes important because of the rate of choose blood pressure. So in hypertensive urgency, you want to get their blood pressure more normal, so to about 160 over 100. You want to make sure that there's no emergency that you're missing to this. So make sure there's no proteinuria, check their serum creatinine, no CNP, their neuro exam. They can discharge home with close outpatient follow-up. And then I liked this because, again, I don't deal so much with the outpatient management of this, but it was a helpful hint that hydrochlorothiazide is a well-tolerated medication in general and once a day and inexpensive. So patients that come through the ED, it's a nice initial treatment for them to go home on with instructions that they need to follow up within a week and watch their kind of dietary intake as well. So patient-dependent selection for this antihypertensive, which is a nice little note about the thiazide. And then based on their comorbidities, they may need other antihypertensives or volume management. So those patients with CHF or ESRD. And if they're really kind of refractory, then they may need IV antihypertensives, in which case they're going to be sending them. You want to always keep in mind that if this is a new presentation and somebody that otherwise doesn't quite fit the picture of someone that would have hypertension, so otherwise young, pretty significant elevated blood pressure. They may have a secondary cause like renal artery stenosis, hormonal or hyperaldosteronism or estrogen, drug abuse, so always be monitoring that, pheochromocytoma, cytostatic disease, or coarctation of the aorta, which is really to treat an emergency, your goal is to reduce the mean arterial pressure by 20% in the first hour and then by another 20% in the next 24 hours. This is to prevent what we've spoken about before, which is that watershed infarct. By that I mean your body's used to a very high blood pressure and you acutely drop it very rapidly. You can cause ischemic complications, most significantly to the brain. of these areas of infarct. However, it depends on what your emergency is. So if your emergency is an AKI, it can be a little bit more slow in how you decrease the blood pressure. If your emergency is a giant intracranial bleed, you want to meet those blood pressure guidelines as rapidly as possible to prevent expansion of that. So that's why we say reduce that blood pressure. You collaborate with neurosurgery, usually with a calcium channel blocker, IV, either retardipine or fluvidipine, and usually shoot for a systolic blood pressure less than 60. The range is 140 to 160 based on which part of the literature your neurosurgeons pay attention to, but it's around there. If they need CPA, if they have an ischemic stroke, they need to rapidly lower their blood pressure to less than 185 or 180 over 110 within an hour, again, using that infusion. And then in acute aortic dissection, collaborate with your cardiac and vascular surgery colleagues for a type A dissection. You get them as low, below 120 systolic as possible, as quickly as possible to prevent them from propagating that dissection. So quick review, I know you've had this before, but acute aortic syndromes, so that includes aortic dissections, a penetrating aortic ulcer, intramural hematoma, aortic aneurysm, or ruptured aortic. So aortic dissection quickly is a tear in between two of the three layers of your aortic wall, so the intima and media, that allows blood flow to go through this weeping area and steals it away from the rest of your aortic fluid. It results in hypoperfusion, and then the biggest risk is that it's going to rupture and kill your patient. Risk factors are things that a lot of people have. So atherosclerosis, hypertension, smoking, connective tissue disorders like Marfan's, bicuspid aortic valve, specifically for your type A or your proximal aortic dissections because of the abnormal architecture of that bicuspid aortic valve. And then again, we talked about this before, rapidly, but type A dissections are defined as those proximal to the left subclavian, whereas type Bs are distal to the left subclavian. That's important because type A's are far more dangerous and higher risk of rupture. The risk is 0.5 to 1% per hour without surgical intervention. Once they develop that. So type B's, you have more time, more often you can medically manage them. Type A's need rapid surgical referral, treatment of their blood pressure. The way that you think of dissections or aortic pathology in the ER is when they have chest pain, hypertension, and then something else. And that something else is a weird symptom that's caused by the disruption of blood flow in the dissected area. So when you dissect kind of retrograde to where the aortic valves take off, you may have the acute aortic regurgitation. You may dissect, if you remember, the first things to come off of your aortic arch are your coronary arteries. So you can have a dissection that's causing that line. Tamponade, so you may get chemopericardium or bleeding into your pericardium from the dissection. Hemothorax, again, from the dissection and the bleeding. Horner syndrome, so your superficial sympathetic chain kind of wraps around your branches of your aortic arch, so you may see Horner syndrome. Stroke or syncope if they dissect into their branch vessels. Difference, the 20-point difference in their bilateral upper extremity pulses, again, because one of those subclavian arteries may be dissected versus the other, depends on the location, so you look for difference in your blood pressures. Paraplegia, you dissect down and you interrupt blood flow to your spinal cord. And organ dysfunction, you see what I'm saying? So it's not just the chest pain and the hypertension, you have this weird other symptom that doesn't quite fit that should start making you think about that versus aorta, especially in somebody with the right comorbidities. Type A is the quintessential symptom that they'll talk about is chest pain radiating to the back between the scapulas. Again, similar to those patients that will say it feels like an elephant sitting on my chest, it's quite surprising how many people describe their pain this way. And once they do, it's a rapid strip to the CT scanner with the CTA as the gold standard for diagnosis. You can get a chest X-ray that'll show the wide and medius sinum. And sometimes you can see that dissection flap on echo, but the definitive diagnosis and what the cardiac surgeons will need to get the repair is that CT angiogram. So please get that. And then we talk about their assessment. The treatment, their risk of death is really, really high. So depending on what you'll see, it'll either be 0.5, you'll see cited in some studies up to 2% risk of death per hour. If you think about the time it takes for somebody to get symptomatic, get to the emergency department, and maybe be transferred somewhere that has the appropriate cardiac surgeon, it's a very, very high mortality situation. And so you want to treat them quickly. It is a surgical problem, but things that you can do medically in the emergency department are reduce this force that's each cardiac impulse has on that tear. So you want to give them beta blockade and you want to decrease their blood pressure using a calcium channel blocker. So, or you can use labetalol too, but we usually use IV calcium channel blockers like clopidogrel or dicardipine and then as well. We're shooting for that heart rate less than 60, that's solid blood pressure less than 20, help prevent the propagation of that dissecting. We talked about the complications based on the anatomy. You can dissect a coronary artery with an MI, like that pericardium, as well as the disruption of the ureter valve. Type B dissection is anything distal to left subclavian, and the time for these patients need surgery is if they're interrupting blood flow to one of their vital organs. So they have mesenteric ischemia, renal dysfunction, or if they have lower extremity weakness or paresthesias, or if they have pain that doesn't improve with blood pressure control. The pain, if you can have a little bit more liberal blood pressure, usually they shoot for a solid less than 140 and upper rate around 80. And they're less urgent than your days. Aortic aneurysms, most common is infrarenal and abdominal aortic aneurysms. That's a weakening of the aorta, not necessarily a tear between the layers. And this becomes problematic when it's rapidly expanding, symptomatic, or when it ruptures. And these are vascular surgery consult. You want to have good IV access on your patient's pain control. Again, the CT angiogram is going to be how you diagnose, and then lowering their blood pressure, almost similarly to a type A if they're actively ruptured. That's the wide and medial assignment you can see. And again, the treatment, blood pressure management, large bore IVs, make sure that you've got blood products ready. Because they're going to get sick pretty quickly if they rupture. Vasodilators, your calcium channel blocker, and your beta blocker can control if you can get certain concentration. So again, I know a lot of that is repeating what you have, which is going to be from that perspective and in the context of that. Any questions about all of this? Ready to get out of here? If you have questions, I'll be here for another 4 minutes. And thank you guys so much. Sorry. Happy to.
Thank you.